Are you able to do that, Dheeraj?
Yeah,
We are actually live on the YouTube now. So it's 6th of May, and today we are doing our COVID rounds, the concepts. We have 4 talks. First one is drug therapy in COVID and a brief introduction to pathophysiology by Tejaswini Murthy. And next one will be by Dr. Dheeraj. Okay. So it's 6th of May, and today we are doing our COVID rounds, the concepts. It is actually repeating myself. I think it's first one is
yeah.
drug therapy. I don't know where it is actually doing that, but physiology by Tejaswini Murthy. I can't make out where it is actually doing that. Next one will be okay. Dr. Dheeraj.
Is your Facebook on, or is that what's causing it?
No, because it was okay. It's fine. It's okay now. So yeah. So next talk is by Dheeraj L on ventilator strategies, and then we have a special guest, Dr. Dominic Morgan, who will be talking about leadership in crisis. And the last one will be by myself. It's about leadership skills to be a COVID warrior. It's more about how you can be a leader without actually having a position, and how you can lead a team. So it's exactly 1 minute past 11. I'm going to hand over to Tejaswini. We call it Teju, and she will start off with that. I think before that, I think need to let Dheeraj actually, because he is the main person who's been organized this. I actually hand over to Dheeraj first, and then he will hand over to Tej.
Thank you, Shiv, and welcome everyone to today's session on COVID-19. I think we were chatting a couple of days ago, me and Shiv, and we were saying that we had a talk on COVID done in the beginning of the last year, probably around May, and then we had discussed quite a few points at that time. But looking at the way the coronavirus has struck in India, and the COVID cases are up on the rise, we thought it was probably timely to share a little bit of experience, but experience not just from the clinical aspect of things, but experience from the non-clinical aspects of things. So the whole program today is divided into 2 sections. The first section is going to be on the clinical management of COVID. We'll have the talk by Tejaswini, and then I'll follow it up with the ventilatory strategies. Once we are done, then we'll take all questions which you have, and we'll discuss at that. If there's any faculty at that time present, we can have a panel discussion kind of thing. After that, we'll be moving on to a very important skill, which I think helps us as anesthetists in our day-to-day practice, which are the non-technical skill. And it's a pleasure and privilege to have Dominic on board here, who's actually even advised the UK government on how to handle this pandemic. And our own motivational speaker, Shiv sir, is going to then come and talk to us about how to be a COVID warrior and what kind of leadership skills you require in this present crisis. So I'd start with the first talk. I request Tejaswini to actually start the talk. She'll be presenting a little bit about the pathophysiology of COVID and a little bit on the drug therapies, or the recommended drug therapies for COVID, what works and what doesn't. All yours, Tej.
Right. So thank you very much for this opportunity. I'm going to talk about, sorry, just give me 1 second. Is my screen visible?
Yes.
Excellent.
Just
so I'm going to, yeah, I'll just start the slideshow from start. All right. So I'm going to talk about COVID-19, a disease which has wreaked havoc across the world. And I have labeled my talk as Colorful Hypothesis of the Unknown, because there is so much that is coming up on this disease, be it with regards to pathophysiology or regards to the drug treatment. It's just massive amount of information. And it was really hard for me to synthesize what exactly to say in this talk for 15 minutes. So I've tried to put a brief introduction on pathophysiology, followed by a brief evidence on the current drug treatment, which is being followed across the world. Okay, sorry. Yep. So financially, I have nothing to declare, and all the images are from Google. And thanks to all the open access COVID research literature with all the colorful images from most of the reviews and meta-analysis. So I'm very grateful to Google for this. So I've divided my talk into pathophysiology and treatment. Moving on to pathophysiology, as we all know, the coronavirus is a single-stranded mRNA virus, which has a spike protein, as you can all see here. And then there is a membrane protein, an envelope protein, and the most important part, which is the mRNA with its nucleoprotein and hemagglutinin protein, which is there again in the wall. This is just a basic structure of the coronavirus. Now, this is this image is from one of the reviews which has been recently published in the BMJ, which talks about the exact role of coronavirus and how it actually causes different phases of illness. Firstly, the first phase of illness, which is the acute phase of illness, involves viral replication when the virus comes and binds to the ACE2 receptor in the type 2 pneumocytes of the lung. And then once the viral replication starts, the illness starts, which is the first phase of the illness. And it is said coronavirus is a biphasic disease, wherein the first phase of the illness subsides after a few days. And then the second phase starts, which includes cytokine storm, which is body's response to this viral infection. And this second phase is also accompanied by a procoagulant state. And in the end, it can result in fibrotic changes in the lung. So this is brief description of the pathophysiology. And this paper actually describes it in quite a bit of detail, but I'm not going into so much detail at this point in time. So as I said, the first phase is the physiological host response to the disease whenever the virus enters, and then there is an early infection stage followed by a host immune response, wherein in the early phases macrophages and dendritic cells and the cytotoxic T cells in the late phases get involved and then cause the illness. But then what is causing most of the other symptoms, which is actually has been the biggest cause of death across the world, is this pathogenic host response phase. So this early phase is followed by a hyperinflammatory phase, wherein there is increased production of inflammatory mediators by the body, and then it can even result in multi-organ dysfunction and death. So this is the phase that is most troublesome. Now, this is my favorite image because this hasn't changed since the COVID pandemic started. This was first published in JAMA way back in 2019, I think 19 or 20, when the pandemic initially started. And luckily for all of us, this hasn't changed. So as I said, this virus goes and sits on the ACE2 receptors in the lungs on type 2 pneumocytes. And then it starts uncoating and releasing its mRNA, which multiplies in the host, and then it starts causing illness. And the next phase would be when the macrophages will go and this is in the early phase where the macrophages will go and try and attack this virus, and then there is release of inflammatory mediators. But the second phase, which is causing the problem now, is the cytokine storm phase. Okay, I like this image because it has given the drugs and where it acts. Right now, the evidence is for 3 classes of drugs. One is antivirals, mainly remdesivir, favipiravir, and then there is tocilizumab and cerulizumab, which are all monoclonal antibodies which acts on the inflammatory phase, and then there is steroids. I've highlighted hydroxychloroquine and chloroquine because initially it was hypothesized that it is going to have a role in the treatment of COVID-19. Okay, so now moving on to the pathophysiology of hypoxemia and so-called life cycle of this disease. So when there is symptom onset, as you note, the y-axis is the PaO2 of the patient and the x-axis is the timeline. So with symptom onset, usually there is no hypoxemia, but then once there is intrapulmonary shunting, intravascular microthrombi, and there is loss of lung perfusion, then hypoxemia starts. And this is the point where dyspnea sets in. So it's very important to remember that dyspnea can set in at the later stage of the disease. Like someone might say, I'm coronavirus positive, I'm fine, but then they become dyspneic by around 8 to 10 days. So it's very important to remain vigilant that you have not exactly gotten over the disease yet. So that's why I just put this slide. Okay, so now moving on to the management. So I've tried to briefly summarize the current available evidence for COVID-19 and the drugs that is currently being used for that. So I have divided my management into first looking at the goals of management. First thing would be to recognize severe illness early, then provide supportive care. It's very important to provide supportive care. Then source control, because we are seeing a lot of cases with mucormycosis. Superadded bacterial infections often get ignored. So we need to have a look at the source control. And then I'm going to talk about specific therapies which are directed at COVID-19. So recognition of severe illness. So this is again from one of the American journals, which showed meta-analysis basically, which actually classified coronavirus into 5 different phases of illness. And not many go into all the phases of illness. What is important to remember that is that asymptomatic or pre-symptomatic carriers will have very low viral replication, but still they have some potential for antiviral therapy, but there is no role for antibody therapy in any of these patients. Whereas in severe illness, inflammation is the most important factor which needs to be kept in mind. And that's why steroids and other anti-inflammatory therapies have provided some mortality benefit, because mortality benefit can only be noted in severe and critically ill patients. So severe illness is when the oxygen saturation drops less than 94% with respiratory rate greater than 30 breaths per minute and lung infiltrates greater than 50%. Everybody talks about the CT score in India. So this is what they talk about, wherein 50% of the lung is involved in COVID-19, then it is termed as severe illness. Now, moving on to the supportive therapy. So early recognition of severe illness is very essential. The supportive therapy I have listed includes isolation, because isolation can be taxing on both the mental state of the patient as well as the physical state of the patient. Provision of appropriate nutrition is very important for any patient. Oxygen therapy if saturations drop to less than 92%. Early awake proning. I'm going to talk about the evidence for early awake proning because it is very important. It's one of the very important therapies. Appropriate hydration, because COVID-19 is a procoagulant state. And early DVT prophylaxis has very good evidence to improve, especially in severe illness and in hospitalized patients. There is very good evidence to show that it has mortality benefit. And then appropriate ICU support, which includes intubation as well. So early awake proning, more than 35 studies have actually examined this, and they noted an improvement in oxygenation, but the magnitude of the improvement was variable because they could not randomize and do a randomized controlled trial per se. And the effects were lost once the patient became supine, especially the magnitude of improvement in oxygenation is what I meant. And this effect was lost once the patient was made supine. So there is an ongoing RCT called COVID-prone study in Canada, which is happening right now, wherein they're trying to randomize patients into proning, COVID patients into proning, and trying to see whether it has any mortality benefit. So what is to be remembered in these prone patients is they require careful monitoring. Because they are prone and they are awake, we need to look for early signs of deterioration, especially measuring respiratory rate, oxygenation, and all of this. And it should not delay intubation, because delaying intubation can also cause worse outcomes. So it is very important to ensure you have adequate monitoring whenever patients are being prone. And so in conclusion, yes, use it to improve oxygenation and also to decrease oxygen consumption. Now, source control, I'm not going to elaborate on this, but then I just thought it is important aspect, one of the goals in COVID-19, because it is a viral infection at the end of the day, and superadded bacterial infections are pretty common in cases of viral infections. So you have to look for mucormycosis, bacterial pneumonias and effusions, and then bed sores, which can happen in these patients because they don't move much, and ensure that you adequately do a source control if these are found in these patients. Now, moving on to specific therapies, the ones which have been investigated so far are the antivirals, monoclonal antibodies, other anti-inflammatory therapies, especially steroids, plasma therapy, some other medications like ivermectin, hydroxychloroquine, azithromycin, doxycycline, which are antibiotics, macrolide and tetracycline antibiotics, and anticoagulation. I'm going to touch upon each of these topics now, looking at the current evidence. Antivirals, the common drugs which have been used are favipiravir and remdesivir, and their mechanism of action has been elaborated here. So what they do is they prevent mRNA replication by preventing the RNA-dependent RNA polymerase with regards to favipiravir and remdesivir. So these are one of the very important class of drugs which will prevent viral replication, basically. What is the evidence though? So in vitro studies looking at all these antiviral medications showed reduced viral replication. There were 3 trials, randomized controlled trials, which were conducted. One was the ACCT1 trial, which showed decreased time to recovery in hospitalized patients, but there was no effect on mortality. This X indicates no effect on mortality in my slides. Bear me with that. Pardon me for that. And in Solidarity trial, which was conducted by the WHO, again, there was no benefit for mortality. And the other trial which looked at it was the phase 3 Simple 2 trial, wherein in moderate disease, remdesivir reduced the time to recovery when given for 5 days. Then there was a meta-analysis which was just published last month and which looked at remdesivir and its effect on mortality. So 28-day mortality, there was no effect, but it did reduce invasive mechanical ventilation and the need for ECMO in this patients who were in the moderate disease group. And then it also reduced the oxygen flow in patients who were requiring low oxygen, and a 5-day regimen showed lesser toxicity when compared to 10-day regimen. So there was some mention about a subgroup analysis which showed some more mortality benefit, especially in patients, in COVID patients on oxygen, but who are not ventilated. So in conclusion, you can give it in critically ill hospitalized patients, but limit to a 5-day course of remdesivir. The next drug which we're going to talk about is favipiravir, which has again been used in multiple centers across the world. So a phase 3 or phase 3 multicenter trial in Russia showed that showed improved viral clearance with the use of favipiravir on day 10. And another phase 3 trial called Presco trial is running in US, but the results are still awaited. There is one RCT by Utpatia et al., which showed that there was no effect on viral shedding, but there was decreased time to clinical cure. But then this study was not powered to detect this difference. So that's why we do not know whether we can take it as a RCT, reliable RCT to assess clinical cure. So finally, two meta-analyses have been done on this. And what was found was clinical and radiological clearance of the disease. There was a positive effect as per both the meta-analysis with the use of favipiravir. Viral clearance, there was no effect in one of this, but then there was positive effect that there was earlier viral clearance by day 14. And the oxygen requirement, there was no effect in one of the meta-analysis, and then there was reduced oxygen requirement in one of the meta-analysis, whereas there was no effect in the other one, and there was no mortality benefit. So for now, there is no strong evidence behind the use of favipiravir. Next comes the monoclonal antibodies, of which I would choose the one which is commonly used is tocilizumab in this disease. And This is the logic behind using it. So tocilizumab binds to the interleukin-6 receptors, and then it prevents its activation and prevents interleukin-6 signaling, thereby preventing the macrophage, thereby ensuring that the macrophage goes and attacks SARS-CoV and prevents inflammatory response as well. So it is an interleukin-6 inhibitor. Earlier RCTs did not show any benefit, but the recovery trial, according to the preprint, shows that there is reduction in the duration of the disease, as well as reduction in the mechanical ventilation days, and also some effect on mortality. The REMAP CAP, which was one trial which recruited patients even in the hospital that I work, Royal Adelaide Hospital, it showed that there was reduced invasive mechanical ventilation in hospitalized patients when tocilizumab was used. And a final meta-analysis, which was published in February, showed that there was mortality benefit, but it is a low quality evidence because of the sample size. So we still have to wait for the complete recovery trial results to say whether it is beneficial. For now, with the available evidence for severe and critical COVID-19 with very high inflammatory markers, within 24 hours of organ support and when given with corticosteroids, it helps to prevent the cytokine storm by reducing the interleukin-6 levels released from the macrophages. The next group of drugs is the anti-inflammatory drugs, which involves corticosteroids. And I'm just going to talk about inhaled steroids as well. With regards to the mechanism, they act through the nuclear receptors to prevent, again, inflammatory release of inflammatory cytokines. So steroids evidence, the biggest evidence came from the recovery trial, which used 6 milligrams of dexamethasone per day. And then there is a meta-analysis which has been done, which includes 1,703 patients, wherein which proved DEXA had a higher effect size when compared to hydrocortisone, when compared to methylprednisolone. So it has been known to reduce mortality, and the mortality difference is quite high. So it has been reduced to it has been known to reduce mortality in severe and critical illness, and the number needed to treat was only 12. Only thing that needs to be remembered is that whenever you put somebody on steroids, you have to ensure that you do a proper glycemic control, and long-term steroid is not recommended. So only for 7 to 10 days is what has been recommended. There have been 3 RCTs which has looked at dexamethasone, which was included in this meta-analysis, and 3 RCTs looking at hydrocortisone versus 1 RCT looking at methylprednisolone. The dose of steroid, as of now, it is recommended to just stick to 6 milligrams of dexamethasone per day, but going with the recovery trial, there is a steroid 2 study which is happening, which is comparing 6 versus 12 milligrams of IV dexamethasone per day, but we still need to wait for its results. So for now, in conclusion, it is a strong recommendation in moderate to severe disease, wherein there is hypoxemia, and it has been known to decrease mortality in this. There is increased mortality if it is given in mild disease, and hence it should not be given in mild disease. So I just put up this chart because often we ignore the steroid potency, and we try to give too much of steroids, because one of my cousins is actually on methylpred, and he is on a very high dose of methylpred. So I just thought I need to put up this chart just to look at the steroid equivalency dose. And what is to be remembered is that dexamethasone is a very potent glucocorticoid. So monitoring blood glucose levels is very imperative whenever somebody is on dexamethasone. The next steroids which are commonly used are inhaled budesonide. The evidence is still emerging for this. So for mild and early COVID in the STOIC trial, it reduced hospitalization in outpatients. But this trial was stopped early. It was an open label design where everybody knew what they were taking, and they did not put up the primary outcome that they were looking for. It wasn't actually hospitalization. So we cannot actually say that there is strong evidence for its use at this point in time. The next one is my favorite, convalescent plasma, because I have been asked, I have got requests from my friends in India asking me whether I could donate convalescent plasma and then send it to India. So it has been the most important thing which has been discussed, I guess. So how convalescent plasma acts is there are already antibodies which are formed in the body in a patient who has been infected with COVID. So these neutralizing antibodies are supposed to have some antiviral effects, and then they also prevent pro-inflammatory cytokines, and they also bind to all of these and then neutralize all the cytokines, complements, and autoantibodies, thereby preventing the cytokine storm, is what is the logic behind usage of convalescent plasma. But it is a blood product, so it carries its risk of all the things that come with it. So the evidence is there is a meta-analysis which was published in JAMA which showed no clinical benefit. So there is no role for plasma in COVID-19 patients at this point in time. So no current strong evidence for its use. So now comes my favorite, because these were the drugs which most of my colleagues and friends and cousins, whoever is a doctor, has already taken. So they were ivermectin, hydroxychloroquine, azithromycin, and doxycycline. I'm not going to talk about azithromycin and doxycycline because they're antibiotics and they have some mild antiviral, anti-inflammatory properties as well. So in a country like India, I think most of us start anybody who comes in with a respiratory symptom with azithromycin or doxycycline. So I'm not going to touch upon that, but I would like to talk about ivermectin and hydroxychloroquine. So most of the studies which were done, they were done in combination of azithromycin and ivermectin, ivermectin and hydroxychloroquine. So we don't have a RCT per se, which has only investigated one of the drugs. There is one RCT which recruited around 100 patients in each group, but still there was no clear-cut evidence whether these patients were also on hydroxychloroquine, where the patients who were on ivermectin group were also on hydroxychloroquine. And there were a lot of side effects, especially because they all prolonged QTC and then they all caused cardiac side effects. So it was pretty, I went through that study and I found it was pretty hard to interpret anything from it. So the way it acts is it inhibits viral entry and endocytosis by multiple mechanisms and some host immunomodulatory effects as well. So ivermectin inhibits important alpha and beta 1 nuclear transport protein. So thereby you presume that it is going to prevent viral replication inside the cell. But these studies were all done in vitro studies using SARS-CoV-2 cell cultures. And there they noted that viral replication was prevented by ivermectin. There was one meta-analysis which showed that there was no mortality benefit, and most of the studies were sample size were like 30 patients, 20 patients. I don't know whether the sample size was determined by a power calculation, but or just because it was done in the initial phases of the COVID pandemic. So maybe they just went in with that. And most of them were not blinded. There was a very high risk of bias in most of these studies. So for now, there is no current strong evidence for its use as per the available data. The next one is anticoagulation in COVID. We know that COVID is a prothrombogenic state and it mimics something, the procoagulant state is something like how it happens in HITS. So whether there is a role for prophylactic antiplatelets or prophylactic newer oral anticoagulants in the management of COVID. So for now, the current evidence suggests to continue antiplatelets for those who are on it and not to start therapeutic anticoagulation because antiplatelets is enough to provide the required cover. For all patients who are admitted to the hospital, you have to give thromboprophylaxis, which we normally do, low molecular weight heparin or fondaparinux for those who are allergic to heparin. So this has been shown to provide mortality benefit in RCTs as well. In one of the cohort studies, not an RCT, in one of the cohort studies involving around 4,000 patients. So it showed mortality benefit. So it is recommended that all patients who are hospitalized should get early thromboprophylaxis. But it is contraindicated in those patients whose platelet count is low. In seriously ill COVID-19 patients, there is no recommendation to say therapeutic intensity anticoagulation should be started empirically. Whereas use it if there is evidence of any thrombotic complications like venous thromboembolism, or there is a history of DVT or pulmonary embolism. So for now, there is no current strong evidence for therapeutic anticoagulation in these patients. I'm not sure about the experience or the emerging studies on this, but in our center, we did not send any of the patients home on apixaban or warfarin post-COVID, and they have all been fine, whoever went home. We had 4 patients die out of the 20, and of the 16 patients, they had not one of them presented with thrombotic complications post this. And that's what I have touched upon. Thank you very much, and please look after yourselves.
Thank you, Tejaswini. I think that was a very interesting and I think a very timely talk, because at present there's so much confusion around what medications we can use for COVID, and the amount of questions which we get asked, all of us on a regular basis, even on the group which we have seen. I think this will go to give people, at present, what are the recommendations and what we need to do. What I'm going to do now is I'm going to start my talk, and I think at the end we can just have a combined discussion on both the ventilatory management as well as the pharmacotherapy for this condition, and take questions from that. If that's all right with you, Shiv.
Yeah, that's fine. Yeah, absolutely fine. Yeah.
Okay, so let me go through the. Yeah, so my screen's visible. Okay, so yeah, good morning, good afternoon, good evening, wherever you are, whichever part of your world you are in. I'm going to talk a little bit on ventilatory strategies and COVID. So as Teju rightly mentioned, what are the pharmacological therapy? One of the main things, once you have a patient who gets COVID and has respiratory complications, is trying to ventilate them. Now, there have been quite a lot of challenges with ventilation with COVID, because I think this is one of the few conditions where I've seen where the same pathology presents with 2 different phenotypes. So ventilation has to be tailored to what your patient has at that moment. I am going to start with a little bit of physiology. As anesthetists, it's very important to know. And the only reason I'm doing this is to understand this equation. We call this as our alveolar gas equation. It's very simple. PaO2 is your FiO2 into P atmosphere minus your partial pressure of vapor minus PaCO2 upon the respiratory quotient, which is usually pointed. It might look like a very complicated formula, but actually it is not. If I were to take, in UK we deal with kilopascals, but generally in India they deal with millimeters of mercury. So I'll try to use millimeters of mercury for here in this. So if you actually look at the inspired oxygen fraction in room air is 0.21. Okay, atmospheric pressure is around 760. If you minus this, which is around 47, for the ease of calculation, we take this as 710. Okay, 760 minus 50, which is 710. If you multiply 0.21 by 710, you get somewhere around 150. PaCO2, if you take a normal PaCO2 of around 40 millimeters of mercury and you divide it by 0.8, that is around 50. Okay, so by this formula, you will actually see that PaO2 is 150 minus 50, which is 100 millimeters of mercury. This according to the formula which we take here. If you're in UK using kilopascals, it'll probably be 0.2 times of 19 here, which is 0.2 times of 95 here, which will be 19, minus your PaCO2 will be 5 upon 0.8, roughly around 6. So your PaO2 is 13 kilopascals. The only reason I'm trying to show you this is that it's very important to understand that the alveolar oxygen concentration can be improved by FiO2. And that is the most important thing you can improve the oxygenation by. The only other 2 things which you can improve oxygenation is either you give PEEP, okay, or you give inverse ratio ventilation, or any other mode which gives inverse ratio ventilation. So these are the only 3 things which you actually, which can actually improve oxygenation. The relation of PaCO2 on this formula is important only if you're breathing air. So for example, if we know that by calculation, this is 150. If a PaCO2 now from 40 doubles to around 80, then you get 80 upon 0.8, that's somewhere around 90. So you see this becomes 150 minus 90. So your PaO2 suddenly becomes 60 millimeters of mercury. But that is as long as you're breathing air. Because if this FiO2, then I give a little bit of oxygen and increase it to 0.4, the relationship of the PaCO2 disappears. So ventilation is always a function of removal of CO2, because your tidal ventilation and your respiratory rate, which equates to your minute ventilation, always will determine what your CO2 is. By simple calculations, all of you know what is oxygen flux, which is the amount of oxygen delivered per cardiac output. That's around 1000 ml per minute. We actually use only 250 ml per minute. So technically, if we were breathing at 1/4 or 1/3 of our tidal volume, we'd still be able to achieve oxygenation. It's very important to realize that even in cases like cardiac arrest, where we actually just do chest compression, the venous oxygen content is enough to provide oxygen to you. Okay, so we ventilate people for carbon dioxide, or if we are not having any joy, by giving simple oxygen therapies. The reason I'm telling you this is that COVID is a condition where we found that if you ventilate someone with COVID, the mortality is around 40%. Yeah, it is a condition where a lot of people die, but they die because of the severity of the disease and the effect it's already had on your lung. I'll cover a bit of it as I go on. The second thing, which in our simple physiology, we always have to distinguish in between what is a shunt and what is a dead space. So normally we know if there is an area which is not ventilated and you've got blood going in there, you get a shunt. So if you see a massive pneumonia, you get a shunt. You can get a physiological dead space. This is physiological, it's mentioned here, but dead space is the same concept. Anytime you have no blood going, but you have ventilation, you get a dead space. That's what you get in a large P. It is very important to realize when you actually have COVID, you might have either of these two, because the pathophysiology, even though Teju explained it brilliantly, we still don't know whether this is a vasculopathy or whether it's something which affects the lungs. So there's a lot of theory which goes on that it starts with a vasculopathy and then it is the damage which is caused by the hypoxic drive which these patients have, or they, what we call as PCILI, or patient-induced spontaneously breathing induced lung injury. So if you're breathing spontaneously and you're breathing with a large tidal volume, you can cause quite a lot of trauma. And that is what then converts of one phenotype where it probably might have just been a vasculopathy to a lung injury, and where we start seeing this ARDS kind of picture. The third simple graph I want to show you is this concept of open lung ventilation. It is very important because ventilation has completely moved to this concept. So if you look at what we call as the compliance curve, there are 2 points which are very important noting. One is called as the lower inflection point and one is called as the upper inflection point. The lower inflection point is at the point with which your alveoli start opening up, okay? And the upper inflection point is the point beyond which how much ever you increase the tidal volume, it is not going to improve. Or how much ever you increase the pressure, it's not going to improve your tidal volume, okay? So it makes sense that if you actually ventilate between the lower inflection point and the upper inflection point, you will achieve the maximum amount of tidal volumes with the minimum change of pressure. This minimum change of pressure is what we call as delta P, and it's actually an independent predictor of mortality. And it has to be, because once we know that your delta P rises, your lung compliance is decreased, there is some problem with your lung. Either it's getting consolidated, either there's a lot of fluid there, or some damage in terms of fibrosis is occurring. So there could be various reasons for that. But the whole concept is that if you actually provide a PEEP, which is above your lower inflection point, and if you keep your P high below your upper inflection point, you're going to get maximum changes in volume for minimum changes in pressure. The other thing which is important to consider is that below the lower inflection point, this is the point at which your alveoli collapse. So every time you're breathing, your alveoli is collapsing and opening, collapsing and opening. This causes atelectatic trauma. So we know barotrauma, we know volute trauma, but atelectatic trauma occurs because of this. And that's the reason why you try to provide PEEP to prevent this atelectatic trauma. Now, this was as I always say, the Bayes theory. This was how we work. This is what we've been practicing for years. Any patient comes with ARDS, any patient comes with a respiratory pathology. I used to use all this to then think, okay, how do I treat with this patient? And suddenly COVID came along, and the problem it was posing was that it was one disease which was presenting in different ways. I was increasing PEEP, nothing was happening. I was having an open lung ventilation, nothing was happening. And that's where we have learned. And that's what I'm going to try presenting with the talk. But I think this is very important, these few concepts to understand before we start on ventilatory strategy in COVID. But as I said, should I be talking about ventilatory strategies in COVID, or should it just be oxygenation strategies in COVID? Because I think most of the time, if you find that these patients, very rarely have what we say as type 2 respiratory failures. All of us, no one knew this word a year ago or more than that, called as happy hypoxic. And now everyone knows that. This is something which is very classical of COVID. And it occurs because the theory is that, COVID causes loss of smell, it causes loss of taste, affects your glossopharyngeal nerve. That is probably what your chemoreceptors are supplied with. And that's the reason why people do not realize the stimulation which a chemoreceptor causes to hypoxia is lost in this condition. And that is the reason why these patients also have normal CO2, because if you find someone has got significant air hunger and they're breathing quite fast, you'll find that the CO2 starts coming down and you may have hypocarbia. But in a lot of patients, we find that COVID patients actually have normocarbia and might have normal CO2, and that's because of this phenomenon. Now, how does a respiratory failure present? So as I was saying, quite a lot of people will present with what looks like a type 1 respiratory failure. Then you treat them, worsens, there's the lung pathology, lung parenchyma, which starts getting problematic, and then you get a type 2 respiratory failure. And by the time you get type 2 respiratory failure, sometimes I think it's not a very good prognosis for these patients, because we've seen patients have CO2s of 10, 12, and this is in kilopascals, so it'll probably be like 100 or 120 millimeters of mercury. So that is not even permissive hypocarbia. That's come to a very dangerous area. And that's where you could use other things, like if you have an institution, ECHO or ECMO, stuff like that will help with that. And it always appears like there is a transitioning from one to other, starts with what looks like a type 1 respiratory failure and then moves on to a type 2 respiratory failure. But it doesn't mean that it's restricted to that. If someone sat home on trying to have some oxygen or proning or doing anything of that sort, they might present quite late to you, in which case their lungs might have already progressed to what looks like an ARDS kind of lung. So treatment of hypoxia, we can have conventional oxygen delivery systems. I think that is what's been a big problem, getting oxygen supplies in India. Oxygen cylinders, you could use all our conventional oxygen methods, like start with nasal prongs. If you have face masks, go with face masks, go to a non-rebreathing mask after that. And once you have had non-rebreathing mask, you're already starting to use 15 liters of oxygen, and oxygen has been a big problem. I was talking to some of my colleagues in the group yesterday asking about oxygen concentrators, and there's quite a lot of move of people sending oxygen concentrators back to India. And people are buying them and stocking and stacking them at home. Yesterday we were giving a talk and we found that what was normally costing 25,000 rupees has now become 100,000 rupees, just because people are stacking it and the demand is going up so high. But conventional oxygen systems have a role in the initial phase, but in these patients, once they start requiring oxygen, we do find that quite a lot of them will proceed to the stage where the cytokine storm has then worsened and they will be requiring something more than that. And that could be provided in the form of high frequency, high flow nasal oxygen, what we call as Optiflow in UK. You would provide CPAP or any NIV, or you go to ventilation. So high flow nasal oxygen is probably the first line of treatment. If I were to do something today, I would go for high flow nasal oxygen, because I think it is a very good way of treating it. It is recommended over non-invasive positive pressure ventilation, or NIV as it is called, in the NIH COVID-19 treatment guidelines in America. So you would actually find that high frequency, I just keep calling it high frequency, but high flow nasal oxygen is probably the best thing to go to. Different countries have different approaches, and I think some countries like UK initially was mentioning CPAP, but they have found that if you actually compare high flow nasal oxygen with CPAP, it gives you more ventilator free days, And compared to NIV, it reduces the rate of intubation as well as mortality. Okay. But one thing you got to beware of is this doesn't come cheap. I'm not talking about the money. I'm talking about the currency of oxygen it uses. It uses significant amount of oxygen. So it can be anywhere from, the minimum we normally tend to put people is on 40 to 50 liters of oxygen, and 40 to 50 liters of oxygen per minute. Yeah. So it is quite oxygen consuming, and probably it's not available in all the places. So if it is not available, then CPAP or NIV could be your option. It is always recommended that if you want to ventilate someone, you should give a trial with CPAP if you don't have high flow nasal oxygen. Okay. It can be used intermittently or concurrently too. So what I mean by that is that if you're having simple oxygen and the lungs look like, they are collapsing now, it's a typical ARDS kind of picture. We know it works in pneumonia. You can give CPAP intermittently for a couple of hours because patients don't tolerate CPAP. We were talking about this in the COVID rounds the other day of how to sedate people on CPAP. And I think if you guys have not looked at that presentation is out there. Please go and have a look at it. We have discussed about sedation extensively there, especially in the setting of the Indian subcontinent there. You could use it concurrently. Sometimes we use Optiflow for some time, and then we try to recruit them using CPAP. So you could do that. Okay. You got to remember that it is an aerosol generating procedure. Okay. There is a group, there was one single study which was done, which said that if you actually spend quite a lot of time on CPAP and then go to intubation, your mortality is higher. But it was just one study. We're just waiting for other studies to come. It really doesn't make sense. I mean, I think the Italians and some other countries were more worried about what we call as the PCLE, or the spontaneously breathing patients causing lung injury. So their concept was that, if a patient is generating high tidal volumes, is on CPAP, and because patients go on NIV, what happens with NIV is that if you're not very careful with what you said, you can get huge tidal volumes. Okay. So someone's very liberal. The compliance of the lung is good. We know that this is one of those phenotypes which we call as the L phenotype. And you have given some oxygen, you recruit them, you're giving extensive tidal volume, and they think that causes more injury. Okay. There is a difference of opinion here. And I think you can take literature as you want. I personally think I don't know much about PCLE, but what I definitely know is VILI. Okay, ventilator-induced lung injury is an established concept. We know if you ventilate someone and put someone on a ventilator, by the second or third day, you can see all the neutrophil migration. You can start seeing damage occurring to the lungs. So that happens with positive pressure ventilation. It's a very well-known fact. So it is deciding what is the lesser of these two evils, PCLE or VILI. But the recommendation still is, the NIH recommendation is that give a monitored trial with CPAP before you think that you're going to intubate someone if high flow nasal oxygen is not available in the country you work in. Awake proning, Teju did part of my work for this, so I'm not going to dwell on it much, but I think my message is also the same. Do not delay ventilation. So if you think this patient requires intubation and ventilation, do not put them on Optiflow or CPAP and try doing proning and waste time in it. Because these patients, it has been shown, they have done studies where it shows that it does not delay anything. It does not delay intubation. It does not improve mortality in that scenario. But it is always worth doing it in the first instance. Okay. Always consider contraindications. There's a list of contraindications I will tell you when we are talking about proning with ventilators. It can be performed in pregnant patients too. And in patients you think it's going to be difficult to prone, consider doing them in a lateral position rather than complete prone, or go in between lateral and prone, what we call as the semi-prone position. Even that position causes benefit. But as I said, please do not delay intubating and ventilating someone who will probably require it, because it's not going to change anything. Now, there are variations according to which country you are and which guidelines you look at. There are different guidelines across different countries. I think what you should do is you should make a risk assessment of your individual patient. What is more important is you should actually make a risk assessment of your healthcare setting. What do you have? How much oxygen do you have? What is the kind of equipment you have? What is the skill mix of your nurses? What are your individual doctors comfortable doing it? It's very important to do that and then decide. It is not one size fits all. At present, there is such a lot of publication which is coming every day. We really don't even know which is, what is a right trial, or the amount of papers which have been churned out of COVID is unbelievable. And you've got all reputed journals also publishing papers and letters and stuff like that. So it can be quite confusing. And probably we have webinars like this throughout the world with people telling you what to do and what not to do. So I think you should make a risk assessment of your individual patient and your healthcare setting. And it is also important, this is not thought about a lot, but you should think about reducing the transmission of risk to the healthcare worker. Initially in the UK, we went more towards CPAP rather than Optiflow, was because of two reasons. One was we thought that the oxygen would probably get over, and I think we almost ran out of oxygen in one of the hospitals in the UK. And my hospital personally had to put another VIE, and we had to do that in very quickly, and then we managed it very effectively. But the other thing which I'm trying to say is the CPAP actually also increases aerosolization. So we had specific units, specific wards which were built for this aerosol generating procedures. Okay, so people used to go in full PPE, used to treat them like we would treat, any aerosol generating procedure like intubation. So you've got to be very conscious of that. But what I was talking about were these two phenotypes. One is called as the L type, and the other one is called as the H type. Now, if people get confused, which is L, which has got more compliance, which has got less compliance. Basically, if you look at it, elastance is the opposite of compliance, okay? So the L type means these patients have low elastance, which means they have high compliance. Okay, that is the way I remember it. So L types are the patients who have high compliance. In these patients, you should try to restrict your PEEP because there is nothing wrong with your lung. The more PEEP you give, you're distending alveoli which don't require distension. And you might be diverting, you might be creating a dead space in that situation. For example, one of the common questions in FRC is that if you give salbutamol to a normal patient, what happens? You cause bronchodilation, you already dilate areas which have a good VQ match, and you actually cause a mismatch. So you got to remember that these kind of patients, one is restrict PEEP. The other one is you might actually cause more damage to them, okay, just by giving the PEEP. Because the COVID lungs are very brittle. There's been incidences of pneumothoraces and stuff like that occurring later on with COVID. So, this is, and what I'm talking about is in the very initial stages, okay? Consider early proning in these patients. Pulmonary vasodilators may have a role, though the evidence for them is not very strong. Low tidal volume ventilation, as you can see, is common in both. You got to have low tidal volume ventilation. This is the only thing which we have really good evidence for, and that is what we should be following as a part of our daily practice. Both require high FiO2. You will probably end up giving these patients 80%, 90%, 100% oxygen, sometimes for days. Don't think about oxygen toxicity or anything of that. Just you need to give as much oxygen as you require to maintain an FiO2. And as you see, adequate sedation also comes in both of them because these patients are very, very difficult to sedate. In addition, in H type, you will probably have to give escalating PEEP, the open lung concept, which we talked about, and increasing PEEP beyond that. You might have to consider modes of ventilation like APRV, and you might have to consider proning if these recruitable modes do not work. People have asked, how do I set up ventilators for these cases? And just for the sake of the PGs who are out there, the common practice is that whenever you ventilate a patient, put in the tube and measure the compliance, okay? So some places you can directly measure the compliance. If you have got a compliance loop, it will tell you what the compliance is. The other in other places, you have to do an inspiratory hold or an inspiratory and an expiratory hold to find out what the compliance is. What compliance is basically tidal volume upon your plateau pressure minus total PEEP. So if you do your inspiratory hold, it will give you what the plateau pressure is. If you do your expiratory hold, it will give you what your total PEEP is. Okay. So for example, I have a patient, I have put on pressure control ventilation, I do an inspiratory hold, it tells me the plateau pressure is 20. I have done an expiratory hold, it tells me the total PEEP is 5. So it becomes tidal volume. If the tidal volume of the patient is 500, it'll be 500 upon 20 minus 5, which is 15, which comes to around 33. Okay, we are worried if your compliance is above 30, we think you're mostly in the L phenotype. If your compliance is below 30, you have low compliance and you're probably in the H phenotype. The other way of doing this is just measure your driving pressure. For example, if I put someone on a pressure control ventilation, or bi-level ventilation, I have put my PV high as 20 and my PEEP as 5, and I'm getting a tidal volume of 500, then 500 is my tidal volume and my driving pressure is 20 minus 5. So it's very easy to set this up. And I think as a rule, whenever you are doing any patient, not just COVID patients, you really need to know what the compliance is. Because if you do recruitment maneuver and your compliance improves, then you know that these lungs are recruitable. Which mode to use? Well, I think we have done a talk on modes of ventilation, and I think it's one of the ICU modules. I would recommend you go and watch there, because I think it's beyond the scope of this talk to talk about each individual mode. I personally am always in a favor of bilevel ventilation over pressure control ventilation or SIMB pressure control. The only advantage of bilevel over that is that you can breathe at both levels of PEEP. At P high and P low, you can breathe at both the levels with bilevel, but with pressure control ventilation or SIMB pressure control, you can't do that. APRV is a mode which you can use, but the best mode is the mode you are most comfortable with. Okay, it is the mode which you work day in and day out. And I would suggest that rather than be in a time where you have a very resource restricted setting, trying to go for a new mode is probably not the best thing to do. I would advise you to actually just go with the mode which you require. But of course, if you require some help in any of these modes of ventilation, please put it on the anesthetic group and we will answer questions relating to that. There's some caveats here. Do not make frequent changes in ventilation. When you actually put someone on a ventilator and put them on a mode, allow it to work. It sometimes takes time to work. For example, if I put a patient on APRV, I usually find that the immediate response is that their saturation starts falling down. It's quite scary. You wait and then allow the lungs to adjust to it, and then you find that it starts to improve. And it takes time to improve. So, you just find people coming and saying, oh, the blood gas is showing a PO2 of 7 or 8, and you're trying to make it to 11. I really don't know what the benefit is, okay? You have to accept a goal and have to make sure that whatever you have set, you will come to that. You will have experience that PO2s of 5, 6, and 7 are very common in COVID patients, despite maximum ventilation, and it is a problem. But you just have to, take your time and just try to make sure that you can get the patient to that phase of ventilation. The other thing is, I always say, adjust as per manpower and training available. Make sure what your nurses are trained in, what your doctors are trained in, and try to do that. For example, if you're a consultant and you say somewhere, oh, I know APRV, I'm going to set APRV, you're going to set that and then you disappear. And it's the poor junior doctor or the nurse who has to look after the ventilator. And if they don't have clue what APRV is, you are in for a lot of trouble. So always adjust your ventilation mode to your manpower and your training, which is available. Guard against your ventilator-associated injury. And as I said, pneumothorax and pneumomediastinum is very common in these patients. Okay, there is a higher incidence of trapped lung too. So if you have a pneumothorax and you put in a chest drain, you will find that these lungs do not expand, sometimes requires 2 chest drain, and sometimes do not expand even after that. There is an incidence of trapped lung, normally is around 0.5% of all pneumothoraces has this, but in COVID patient, it's been shown to be up to 15%. So be very careful about that. So this is just a few X-rays which show about, these are all COVID lungs. You can see the lateral consolidation on both the sides, but at the same time, you can see some pneumomediastinum occurring there, yeah? And you can see that rim of pneumothorax there. Plenty of subcutaneous emphysema in this, and this is very self-evident. It's a very large pneumo on this side. So if you are experiencing pneumothorax or pneumomediastinum, do not worry. I just Googled pneumomediastinum in COVID, and this is what could fit in one page and on one slide. There are so many cases. It occurs a lot, okay? So don't worry about it. Put in chest drains, bide your time. Do not pull your chest drains till your patient comes to a spontaneous mode, all right? Keep an eye on that. Of course, keep an eye on your inflammatory markers. The other things which you normally do, put it on a little bit of suction. Try all the methods which you would do for a large pneumothorax. But do not be scared about it. It is a very common occurrence. So the goals of ventilation, again, has to be in 4 strategies to improve oxygenation, timing and duration of these interventions, decide on an acceptable PO2. A PO2 of 8 is acceptable. Yeah, you do not need anything more than that. A SAT between somewhere around 88 to 96. Maybe if you're slightly conservative, somewhere around 92 to 96 is fine. Anything above 96, superoxia is actually shown to be more harmful in any group of patients. So you do not have to strive for that. So strive for an acceptable PO2. Identify which mode works in these patients. And it has to be very individualized. I've seen some patients who do very well on bilevel. At the moment I put them on APRV, they worsen. Or some people who do very well on APRV. So there is no one rule for everyone. Just tailor it according to the patients and what you have. I'm just going to quickly run through a few things which are always useful for any patient. If you have any patient with severe refractory hypoxemia, these are the things which you need to do. Try a neuromuscular blockade because it prevents ventricular dysynchrony. It permits you to have your arch network ventilation, low pressure, low tidal ventilation. Prevents ventilator-induced lung injury, and some say it may benefit in reduction of pulmonary inflammatory mediators. Okay, that is, it does that by reducing the amount of tidal volume, because the more tidal volume you have, that's why you get inflammatory mediators. That's what causes the problem. And RC tests have shown improved mortality by early usage of NMDAs in non-COVID patients. Okay, but in COVID patients, we have found that we have had to use it. Normally, I would use it only for 48 hours, and that's the reason why. The reason is because it's associated with critical illness, neuropathy. But what we have found in COVID patients is sometimes you have to use it more than 48 hours, sometimes for 72 hours, sometimes for 96 hours. Sometimes we have stopped paralysis, and then we had to restart it in a couple of days. So this is where COVID is slightly different from your conventional ventilation. So you might have to do this. Low tidal volume ventilation, I don't think so at this point of time in intensive care. I don't even have to stress this. This is what you need to do. Okay, you have to ventilate someone with 6 to 8 mL per kg. Okay, restrict plateau pressure to less than 30. These are the 2 rules. Every patient should be ventilated with 6 to 8 and restricted plateau pressure. Okay, and we know that lowering of your delta P is associated with improved outcome. There have been some studies going on ultra-tidal ventilation, but I don't think so. I would discuss it here in this context. High PEEP or not? Well, I mean, there are fans of high PEEP, there are fans of arch network thing. I personally start getting scared about, a PEEP of 14 or anything above that is my no-go territory. I might go up to 14, some patients 16, but I'd never go on top of that. The arch network sometimes goes to 20, 22 and stuff like that. The thing is that there have been studies which have been recently conducted where you have actually seen this, what we call as a staircase maneuver for recruitability and high PEEP, and they found increased risk for harm in these patients. So I think there's a definite cohort of intensivists who really do not go. For me, if I have to go to that level of PEEP, I will probably put my patients on APRV rather than put them on this. So that is what I tend to do. But PEEP helps recruit lungs, especially in the age type where we are finding that they're going through ARDS. This is what we need to do. Higher PEEP improves oxygen, but not mortality. This is very important to realize. Yeah, so mortality benefit in ITU is shown to be only with a very few maneuvers. Okay, and with high PEEP also it shows improves. You can improve that number, that PO2, by doing a lot of maneuvers. But ultimately, many of these maneuvers have not been shown to improve mortality. Okay. As I said, recent RCT has shown that supranormal PEEP increases mortality. And what we were talking about, lower inflection point, is that majority of ARDS patients have a lower inflection point less than 15. So even if you go to a PEEP of 14, and that's the reason my justification of staying around 14 and 15 is that I know that I am beyond the lower inflection point in these patients. But this is just for ArchNet. If you have not seen it, look at those numbers, 18, 24, they are very scary. I do not, I stay away from them. I see discretion as the better part of valor when it comes to this kind of PEEP. Recruitment, I'm sorry about the spelling mistake, but recruitment is basically a dynamic process which opens atelectatic lungs. Okay, you have to see whether a patient is recruitable or not. The potential for recruitability is variable. This can be achieved by sustained inflation or inflation or an incremental technique. But as I said, incremental technique or staircase technique is out now. But if you're not going to go to the levels of PEEP which they did, I think you might still be okay. And recruitment always has a potential for harm. Okay, then I can't stress about proning patients. Okay, if anything, COVID taught us more than anything else is that we can prone patients. Proning actually improves oxygenation by alveolar recruitment, redistribution of ventilation, elimination of compression of the lungs by the heart, reduced atelectasis, and improves your chest wall as well as your lung dynamics. Previously, for years, we knew anecdotally that proning worked. Nice to prone patients and it used to work. And suddenly we had all this literature coming saying, oh, no mortality benefit. It improves oxygenation, but not mortality. Until this study came. This was one of the studies which actually showed mortality benefit. And it was very clear in their conclusion that early application of prolonged prone positioning sessions significantly decreased 28-day as well as 90-day mortality. But what was practiced or what was done in this study was proning patients for 16 hours and doing it twice. In COVID, what we learned for COVID patients is that this rule of 2 is out of the book. Okay, sometimes you have to do it twice, thrice, 4 times, 5 times. And what we also found is sometimes if you actually prone the patient worsens. Okay, so you have to bite the bullet, you have to turn the patient supine, try other methods, try different modes of ventilation, and then prone the patient. And then it works. So you have to be a little persistent, and you will. There is nothing in COVID patients which will give you immediate joy. Okay, you just have to bide your time. Yeah, you will have to try things again and again, and come to whatever works for that specific patient. As I said, tailor your ventilation to specifics. Contraindications for prone positioning is very, very important. If you do not have trained staff, please do not attempt it. If you dislodge a tube on a patient who's already on an FiO2 of 100%, you don't have anywhere to go. It is very, very difficult. But what we did in the UK and what worked very well is we had what was called as proning teams. These didn't have to be doctors. Yeah, all you required is a doctor to hold the tube when you're proning the patient, an anesthetist specifically to hold the tube. And the rest of the people could be a team. This could be a team of volunteers who want to come. Yeah, all you have to do is train them, teach them how do you prone the patient, how do it safely. You can practice on a mannequin, you can practice it on another colleague. Once they are done, if we had to prone the patient because of manpower resource problems, what we used to do is we used to decide in our morning rounds, you're going to prone this patient, prone this patient, prone this patient. And in the same way, while the proning team were there, the patients who were proned yesterday were deproned. Okay, so we used to time it like that. So when the team came in, the proning team came in the morning, they used to deprone the patients. And then they used to start proning the patients. So by the time it was 3 o'clock, 4 o'clock, they prone the patients. By the time it is sort of 8 in the morning, it's 16 hours. So that was our rationale. So they came in, the team used to deprone, and then the team used to prone. Okay, if you have a patient with an increased intracranial pressure or increased abdominal pressure, of course, that's a contraindication for that. Abdominal chest wounds, this is just in context of everything else. C-spine precautions. If you have someone who's come for as a trauma patient and then develops COVID, because one thing which you've got to realize is there's an entity called as hospital-acquired COVID, okay? And we found that around 20 to 30% of the patients, or at least 1 in 5 patients admitted to the hospital can get what we call as hospital-acquired COVID. So you have to be very vigilant around that. Extreme obesity, if you can't prone the patient, then at least try to semi-prone the patient, okay? And it's probably not the best thing to do with someone who's got hemodynamic instability. High frequency oscillation, well, I don't think so. We tried it. I don't think so it has any role. It worked very well for swine flu. We used quite a lot when swine flu was there. But then there was a study which was published, which actually showed that it was not beneficial. I have to be very careful of some studies. Yeah, there have been some really good drugs which have gone out of intensive care because of one major study coming and showing some problem. But as I believe in IQ, what I've seen is that it comes in circles. So we'll see where it goes. But it did work very well for swine flu. It reduces, because you can deliver very, very small tidal volumes and it's supposed to be lung protected. But it's just the amount of pressure which is there in your lungs maybe causes more damage. We don't know about this as yet. So at present, for this point of time, it is out. ECMO, I mean, you could either have it veno-venous, veno-arterial. There was this big trial called a CESAR trial, which showed a mortality of 63% versus 47%. Received a lot of criticism because of the study design, because of what they compared, because, out of all the patients they recruited, only 76% received ECMO. There was a lack of management plan in the conventional group. So it was ECMO for one and do whatever you want with the other one. Okay, so there was no protocolized care for that group of patients. And, the relative risk was not for the ECMO, but was for the center which did the study. And it was a single center study, if I'm not wrong. This was done in Leicester. But I think still there is a role for ECMO. Okay, there was another study which was called as the Elliott trial, which showed no more mortality benefit at day 60. But what ECMO showed is that if you actually have a proper protocolized care, which was done with the ECMO group, you had better, it caused benefit, and early intervention showed benefit. So that is the reason we started referring to ECMO centers quite early. Okay, it was very useful for H1N1 epidemic. I think it is a very useful tool for patients who have alveolar hemorrhage. It was widely used during COVID. I am not unsure about any studies which have been published which have shown overt benefit with this. There are two scores which are used with ECMO. One is called as the preserve score. One is called as the RESP score, because you have to decide whether ECMOs will be beneficial for the patient. If you look at this, this is the preserve score which is used. And if you can easily see that once you start having a preserve score of 5 to 6, your mortality, your probability of survival is 60%, 40% mortality. And once it goes to a score of 7, it's like, your mortality is very, very high, in almost close to 80%. So probably at that score, I think probably around between 5 to 7 is the score. People will start deciding whether they can take the patient for ECMO or not for ECMO. The score which was used by the center which we refer is called as the RESP score. And they were using a number anywhere between 3 and 2. And you could see that, estimated survival dropped below 60 with a score below that. And hence, because there was no absolute evidence for that, I think ECMO was not used in a patients with a lower RESP score. Well, other intervention you can do for any patient is restricted fluid therapy. Steroids, of course, you use dexamethasone. What I meant by steroids here is that in ARDS, we use what is called as a Meduri protocol, which can go on for longer. So whether there's a role of doing that. The dose of steroids, as Tejaswini mentioned, was about 6 milligrams. But in our ITUs, we went to a point where we were using higher doses than that, higher than even 12, probably 18 milligrams sometimes. Or we were using pulsed methylpred if they were not responding to dexamethasone. So we'd use, like the dose we use for vasculitis, anywhere from 500 milligram to a gram for 3 days. But that was pulsed only for 3 days and then stopped. Our pulmonary vasodilator, as I was talking yesterday, we said that if you actually use pulmonary vasodilators like either nitric oxide, or you could use inodilators like inoxamonone, or you could use nebulized milrinone, or we were using prostacyclin. It is more for a diagnosis. It will also improve oxygenation, but it is not going to improve your mortality. And that is the reason a lot of centers don't routinely recommend the use of pulmonary vasodilators. But if you're in a place where your patient's oxygenation is not improving at all, maybe something to think about. In conclusion, the mortality in these patients is around 40%. Okay, these patients require prolonged ventilation and increased sedation. Many may require neuromuscular blocking agents beyond 48 hours. These patients have significantly increased sedation requirements. A lot of these patients will end up with a tracheostomy. Now, I know there are two kinds of schools in ITU. One do the early tracheostomies, the other do late tracheostomies. I am not a school for early tracheostomies. My whole practice is waiting for at least 7 to 10 days before I do a tracheostomy. But in these patients, if your patient is on high levels of oxygen, the only way we could wean them was tracheostomy. One was because of the sedation need, which is huge. The potential for having neuromuscular blocking agents and already having such a high risk for ITU neuropathy, myopathy. And I think that one of the things which we found out very fast was doing tracheostomies really helped us with these patients. And the best strategy is always dependent on what resources you have, what is your manpower, and what is the training of your staff. With that, I conclude my time. Thank you very much. Okay, so Shiv, do you have any questions, or should we start with questions?
There wasn't. I mean, obviously there wasn't a question which was answered whether the high flow nasal oxygen is aerosol generating procedure. Yeah, it is. There was a comment about one from Dr. Vasanthi Vidyasagar, who's from Chennai, and she said one patient died within few hours after pneumomediastinum in spite of drain. He was just 38, didn't have anything else.
That's sad.
But I think.
So other thing which you need to do with the pneumomediastinum is once you actually have pneumomediastinum, try to change your ventilation to prevent further damage. In the sense that there is no point of continuing with a PEEP of 12 or 14 or APRV once your patient develops pneumomediastinum. Come back to your basic. Get your patient on bilevel. have a low PEEP in that case. Your oxygenation might fall to a lower level, but then just accept it, because the other risk is just developing a massive pneumothorax and dying. So this patient probably developed a massive pneumothorax and died, looks like, isn't it? That's what happened. It tensioned and then died. So I mean, watch out for that. It is quite dangerous. But what I was saying in the COVID rounds the other day was the same, that we have seen a lot of patients develop this, and a lot of patients make out of, even if they have pneumomediastinum and pneumothorax. Do not think that this is somehow a bad sign. Okay, it is just a sign of bad lungs which occur with COVID. So you can tide over with that.
There was another one, I think, again, you actually mentioned about this. And this, I don't know who this person is. He said, I have personally seen patients getting more uncomfortable and dropping saturation once you turn them prone. Why so?
I mean, I think, as we said, proning doesn't work on everyone. It just depends on where your lung is affected. I mean, proning primarily works where your dependent areas of lung are more affected, isn't it? And you got to realize that what we tend to do, what I think we did in a couple of patients, is we proned them. We found the saturation was not doing very well. We reproned, turned them supine. We started them on pulmonary vasodilators, sometimes with prostacyclin, and we found that we could then turn them prone. In some patients, we shifted the mode of ventilation. If they were on bilevel, we went to APRV, improved their saturation, and then turned prone. So proning is not going to, this is exactly what I mentioned in the talk. It won't work every time. Sometimes you just have to accept that it's not going to work, but have a strategy. But just because someone failed proning once doesn't mean that you don't try again. That is my message to everyone.
Also, sometimes it might be an early effect, because it doesn't improve oxygenation immediately. It's not like a magic. You just have to buy some time and just wait. Sometimes you just don't go turning them. So you need to actually, I think, it's not mentioned whether this was about self-proning in patients with mild to moderate COVID, or was this in patients who are ventilated? So that's not mentioned.
But as I said, Shiv, it is very important. Any intervention you do on a ventilator, give it time to work. Do not expect it to work magically. It doesn't. It doesn't, even in normal setting, it doesn't. So you just have to give it time to act. I think you need to persist for a few hours before you call that the mode has failed. I mean, generally we try to, that protocol, I didn't want to bore everyone with that, the one which we had at the last slide, but we generally tend to take failure as failure to improve within 6 hours. So that's the thing. But what you have to be very vigilant across is, of course, if you have prone someone and the SATs have dropped from what was 90 now to 70, you can wait for some time, but if it's showing a continuous trend, then you have to turn. So you've got to recognize, and I think most of us in ITU recognize that what is an immediate bad effect and what is a non-improvement. So I think if someone has worsening SATs and has problems which could immediately cause damage to the patient, of course you have to abandon it, say we'll try it again. But if it is like the SATs has dropped from 90 to 86 or 85, just wait, give it time. It will come up. It does come up. Oxygenation definitely improves with proning. But I agree, there is a select group of patients it will not work at, and in that situation, be ready for it.
Another thing which I would like to mention is that some people actually use it like as if they're doing a prone in patients who are actually having surgery on the back, and they tend to actually disconnect the ventilator.
Yeah.
So what all the advantage you have of applying the PEEP and recruiting the lungs, de-recruitment occurs, and that's why you actually initially see desaturation or no improvement. So it takes time in that as well.
Yeah.
So whether you recruit the lungs again after proning, that might be another thing to actually look into.
I think it's a very important point. I mean, I think in any ITU patient, if you are actually disconnecting, you have to clamp the tube. You have to do something with which you don't lose PEEP. And as you rightly pointed out, that if you actually lose the PEEP, then you have to recruit them again. That is very, very important.
Yeah.
I have a few questions for Teju. Can I ask them? So, because from the pharmacology point of view. So, Teju, remdesivir, if you showed us the graph, and it was like the viral replication occurs quite early, isn't it? And once the viral replication occurs, then you get benefit of, so what remdesivir has been shown is to decrease the viral load. So why then they say that you use it for moderately to severe COVID, once the damage has already happened? And the other thing which I wanted to ask about remdesivir was that does it work because, we are using dexamethasone, and we know steroids actually delay viral shedding massively. Okay, that is the reason why initially we never used to use steroids apart from this condition. So does it have a role like that? So just what's your take?
From the meta-analysis, so what exactly was found was that remdesivir helped in patients who were not on mechanical ventilation. So I thought that they prevented viral replication at a very early stage, and that's why they were beneficial. But then because it is an IV medication and it is given in hospitalized patients, so I thought like it might be that steroid is also playing a role, and they have not actually dissected which one has the effect size of remdesivir versus steroid in patients who are getting both. That was my perception, sir.
Yeah, it is. So I think that if you look at it, there's no individualized randomized controlled trial, which is very good. The only one which was good was the ACTT trial, isn't it? It showed decrease in hospitalization by 2 days. I think that was their endpoint. There was no mortality benefit. And suddenly you have a meta-analysis then showing that it might have mortality benefit. That makes me wonder what the other studies are which were taken into this meta-analysis. So I think sometimes systematic review and meta-analysis, you have to be very careful on the quality of the studies which are done with the meta-analysis. What do you think?
Absolutely. So but just because it's an RCT, most get included, but the sample size, whether they were actually looking at that as primary outcome, because this mortality benefit was in that subgroup analysis as well. So it's like you really don't know whether they're actually, the study was powered to detect this outcome. So I think that is where most of the studies, smaller RCTs, which are included in this meta-analysis, just add numbers to the analysis, whereas they don't actually add the effect that is needed, I felt.
Yeah. Dexamethasone also, it was very interesting on your talk. I mean, I think Dex is probably here to stay. I mean, I always used to use dexamethasone before I extubate someone, because there's evidence showing that you use 2 doses if your patient's on prolonged ventilation. Now there is evidence of steroids which have come in a community acquired pneumonia in septic shock. Now there is evidence, there are studies going on of dexamethasone in septic shock per se. So what is your opinion about dexamethasone?
I think the lack of mineralocorticoid effect of Dex makes it a very safe steroid as long as you're able to control the glycemia part. But then I'm not sure about the high dose, because I did remember that you had mentioned about high dose dexamethasone. We've only used so far 10 milligrams maximum dose BD for anti-inflammatory effects in those patients with difficult intubation, tracheal edema, maxillofacial surgeries. So it has a very good anti-inflammatory effect, which is actually quite visible for most of us. So I think that is the best part of DEXA without having mineralocorticoid effect. It possibly doesn't affect all the potassium and sodium milieu in our body, I feel. So I'm really not sure. I mean, it does have anti-inflammatory effects, which are so widespread. And in diseases wherever there is cytokine storm, like COVID, where all the interleukins are elevated, so possibly it is much more pronounced. So it would be really good drug. I hope we stop using it for nausea, though.
Well, I mean, ivermectin, actually, it was interesting you mentioned about the lab studies, isn't it? Because it's a drug which has been used widely in India, plus it's on the policy and protocol of some ICMR thing too. I mean, it was very important to point out that ivermectin, which was used, was basically, it was in vitro studies, isn't it? Which they used that?
In cell cultures and in vitro studies.
Yeah. And I think the other thing which was very important to understand there was the dosage which they used is actually, you can't replicate it in humans.
Yes.
So that was at that kind of dosage, they showed that it was effective. So that dosage we can never use in humans anyway. And that's the reason
1,800 milligrams or something. Yes, massive doses.
The last question to you, I'm sorry, I'm asking you all the question, but I thought I just, there are a few points which I made. Was one thing which you didn't mention is that, the CIPLA has released an article today in India that COVID cocktail antibodies are going to be available in India. So Cipla, as it is, with remdesivir
I
stock.
saw that cocktail of
So
monoclonal
I think
antibodies.
they are using it in the US, and I think if I'm not wrong, they have found it to be effective. I know there's unofficially they say even Donald Trump received a antibody cocktail at that time. There were rumors about that, and it is probably the only place it's used. So Shiv or Teju, have you heard anything about this? Do you know if it works, or is it
Not
something
about these
else?
antibodies,
I
sir,
should
but
have bought stocks in Cipla.
Yeah.
not about these antibodies, but I did read up that FDA had approved ivermectin, hydroxychloroquine, and all of that, and they withdrew the approval. So I won't be surprised if this antibody cocktail will be withdrawn soon as well.
My only worry is that the way people have been stocking things at home in India, when they heard about remdesivir, when they heard about tocilizumab, when they heard about ivermectins, people, oxygen concentrators, they've got all this just in case they get COVID. I wouldn't be surprised if this flies off the shelf, but and we're happy to be guided if there are more studies about that. I personally have a feeling, I think in America they do recommend it, but I don't think so we are using it anywhere else. I'm not sure whether, Shiv, do they use it in your hospital? Do you know about it?
No, I'm not aware of these at all. So I think this is something new. Yeah.
So any other questions, Shiv?
Yes, I think one of the things I think which I would like to say about remdesivir and the antivirals. If you look at the literature, I think most of the literature has actually come from the West, where they were actually used pretty late. The whole concept of actually using remdesivir is to actually reduce the viral load early, and that doesn't actually happen. And the patients actually don't come to hospital in a stage when actually it could actually help. So it's always started late. So it's not that there is no role of antivirals. I mean, if you can actually use oral antivirals in the early stages, it will reduce the viral load. But what is happening, I think, sorry?
On that note, we ended up using oseltamivir for our COVID patients when they
I was going to
presented.
exactly mention that. Oseltamivir saying the same thing, or when its swine flu started, even though we knew that we were not seeing any benefit, but then it was like mandated give oseltamivir, and I think it was at Coamax class. There was a combination which we had to give all these patients who came in. So I mean, I think if there is I know there is a couple of literature which has been published in India where they are using some oral antivirals, and it seemed to be working. So of course, if anything has been shown to be of benefit and it can be used, we will definitely use it. But a lot of patients, I think, even in that ACTT trial, I don't know whether they were using it late. I think they did use it. Was it only for hospitalized patients?
They were already hospitalized patients, and I think that's the problem was. I think they, if I'm not wrong, in India they are actually using favipiravir, which is actually I think available orally as an oral formulation. So people are actually using it, and there are people who say yes, there is actually, I think, benefit of that. The problem I think in India is early use of dexamethasone. They are introducing steroids too early. And I think the graph which Teju has shown is very, very important. At what point you actually introduce dexamethasone, that is very, very important. And in I think in general population, it should be that unless until your saturations are dropping below 93%, you do not actually start the patient on steroids. They are probably causing the kind of mild to moderate to move into severe kind of disease with using early, and they're using high doses of steroids. And that comes to a question. There is a question on that by Dr. Vasanthi again, and she was actually saying that dexamethasone in 2, 4, 8, etc. Why 6 and 10? I think this need to be actually be cleared that in UK, the dexamethasone is available as 6.6 milligrams, which is actually equivalent to 8 milligrams of dexamethasone phosphate. So I think that's the only thing. So I think that's the conversion factor is not mentioned, and I think that they should be very clear. So it is almost 8 milligrams equivalent to what is available.
The thing
And
is
also,
that
I think the
remdesivir, what I wanted to add on remdesivir is it's quite hepatotoxic. I mean, it has got toxicity properties. You got to make
Yeah,
sure that it is not a very benign drug. So
it is
if
not.
it's
Yeah,
a drug which
yeah,
actually has no benefit but
yeah,
can cause harm, or has slight benefit but has cause harm, has to be a
yeah,
risk assessment thing.
yeah,
And
yeah.
what I'm worried about is people taking the drugs by themselves rather than going to doctors and taking these drugs. But
I was going to mention that. So
it's
the steroid usage is actually because many people are self-medicating themselves with methylprednisolone
Yeah,
from the
absolutely.
literature.
yeah.
So like I have my own cousins who are software engineers. Both of them have started themselves on 40 milligrams methylprednisolone every day.
Yeah,
And they
big time.
haven't got a COVID test done.
Yeah, that is the worry. That is the worry, isn't it? They may
It's
actually
very
make their own disease more severe by doing that. And there are actually a few more questions. Well, I think one of the things which wasn't the two things, and this is again Vasanti, Dr. Vasanti talking about. It says maybe silly, but what about methylene blue? Has that been used? This was asked to somewhere else as well. Methylene blue, hasn't it been used? I've not seen it been used in the Western soil
So
anywhere.
methylene blue, the only time we were using methylene blue was in severe sepsis and severe
Yep,
septic shock.
yeah,
And
Vesophagia.
that was in severely vasoplegic patients.
Yeah,
And there was, there was a mention that it might work. So this was something probably around, maybe around 10 years ago we were trying, but I think it just went out, we didn't see
yeah.
any more benefit out of that. So we don't use it anymore. I don't know what, in Australia, do they use it? Did you?
I have used it in two patients.
Mm.
They were gray. I mean, they were about to die, and they became blue after we gave methylene blue and died.
So
So
Okay.
that's what
you went to gray to blue.
that's exactly what my experience was. We gave 2 milligrams per kg body weight in two patients who were severely septic. They were on this trial where we were trying to investigate angiotensin versus NORAD in
Yeah,
sepsis. And then they were in the NORAD arm. And then it was at the last stage wherein they were on very high dose vasopressors, but methylene blue had no impact according to my experience. But then I don't think there are any studies which have actually shown methylene blue to be useful in reducing vasoplegia in this. In the center that I work currently, I have not used it. And there was something about inhaled methylene blue as well, so
yeah, yeah. That question was actually asked on the group, and I said, "Oh, only
was
thing
it?
you do is have make blue everywhere. Yeah, it will be dispersed everywhere. I don't know how much is going to go locally, but it'll be absorbed. But I don't know. I think people tend to actually try everything. So that comes to another one, which is actually another question asked by Daljit Singh. He says, any thoughts? Because this has been asked a few times on the group again. Baricitinib and a GAK inhibitor.
JAK2 inhibitor, the
Yeah,
JAK inhibitors.
yeah, JAK inhibitor. Baricitinib. I don't know where they get this kind of names.
There were 8 drugs which have been tried but
Yeah,
never underwent any RCTs. Everything
yeah,
says that 8 drugs are currently undergoing randomized control trials, and
yeah,
this was amongst that list as well. So it's
yeah.
possibly wait and watch for now for the JAK2 inhibitors.
Absolutely, absolutely. I think this is all investigatory kind of drugs, which I think we need to wait for. I
I
think it's
think,
already 12:30. I think
uh,
we should actually move to Dominic's talk.
yes,
He's
we
been
should.
very
The,
patient in
the
listening
only
to us.
the only last point I would add is that one of the drugs which went severely out of favor in ITU was something which we were using. Do you remember in sepsis, Teju? We were using uh, the name will come to me.
Oh, the massive 200,000 costing drug, which was, I can tell you just a minute.
Don't worry about it. So I won't keep Dominic waiting. I think so. We have the pleasure of having Dominic with us today, who's going to be our guest speaker. And I think we have covered a lot on the clinical part. And I think it is time to move on to our next part of the show, which is the non-clinical skills. This has been a disaster of the proportion that our generation has not seen before. And I think it has affected all of us in very, very different ways. I'll let Dominic introduce himself and get on with his presentation. So Dominic, all over to you, please.
Thank you for that. First thing to say is that just for those people who don't know me, I am Dominic Morgan, Director of Operations for Inspire Health. My background is 30 years of dealing with incidents, major incidents, international disaster response, both in response, training and healthcare development across the UK, and as of course Director of Training across the UK, US and Canada, disaster response teams. So everything I'm going to talk about is essentially comes from that background. On top of that, I was part of the UK first medical teams into Kashmir in 2005, Haiti in 2010, and Nepal in 2015. So I've been on the ground and seen lots of disasters. So I'm going to just share my screen. Hopefully that will work. Okay, hopefully you can see that. So we're going to talk about leadership and integrated crisis management. So quite a departure from the clinical aspects of this meeting, but recognizing that actually we're all in this together and experiencing, a lot of us experiencing this for the first time. And disaster response is quite a small area of medicine in the sense of its understanding and its impact. And we don't normally see this in our day-to-day business. So this is really useful to try to get people to understand where we are and how we actually manage crisis as well. So the first thing to say is that this is unprecedented global emergency. And what we mean by that is not that we haven't had pandemics and epidemics. We've had SARS, we've had MERS. What is different about this is the impact of this pandemic. The last time there was anything of this scale was in 1918. So none of us that are alive today would have effectively dealt with this scale before. So what do we start with? Well, essentially what we do is we ask ourselves a question whenever we deal with disaster response. And it's really important that we ask ourselves that question. Is what does success really look like? Because it's important that when you're dealing with crisis, you understand right from the beginning what you're trying to achieve. And we're asking about what does success look for you, for your patients, for your family, for you, your team, your health care system, your country, and also globally. It's really important that in disaster response that we think about all of those aspects at once. There are two main impact crises, and we're going to talk about the impact of crisis. And it's really important that we understand the differences between the two because they end up in the same place, but they start very differently. So there are two main crisis impacts. And the first one is a sudden impact crisis. And that can be anything from an earthquake all the way to a road traffic collision. It can be any type of crisis that occurs. It's not foreseen. You haven't really seen it coming. You might know that it could exist, but it wasn't planned. You didn't see it coming. It was a sudden impact. The second one, and the one that we're dealing with now, is actually far more serious. And that is a rising tide disaster, of which the worst type of rising tide disaster is a pandemic. And the reason for that is because it has several impacts. Although they both end up in the same place, because of the way it starts, it changes. So what happens in a rising tide disaster is we start with novelty. It's normally an event that doesn't occur directly to you. It's an event that occurs somewhere else. And it really is about interest and novelty. And in this case, it happened in Wuhan, in China. And we had MERS before, we had SARS before, they didn't get to the UK. Why would it come now? So there was an element of novelty and interest about it. But what happens in a rising tide disaster is that it doesn't stop. It's not a one-off event. A pandemic continues to spread. And then that novelty interest gets replaced by concern. We're starting to question now, is this something which could break out of China? Is this something which we're starting to see cases around the world now in other countries in the region? And that's exactly what happened in this case. So we all start to get a little bit concerned about ourselves, our own healthcare systems, our own family, all those questions that we talked about, what does success look like? That concern can quickly become replaced by anxiety. Now, anxiety is where we're really questioning now. We're really questioning, are we prepared? Is our healthcare system prepared? Even though we've said we're prepared, are we really prepared? Is our government taking it seriously? Do we have the resources available to us? What happens in a rising tide disaster is that quickly becomes replaced by panic. And that's something we've seen particularly associated with the COVID pandemic, but actually particularly in this acute phase in the subcontinent. Because what we're seeing, and as was discussed in the clinical side, is many people are taking their own individual actions, hoarding drugs, getting equipment, starting self-medication, as we've discussed, which is in many cases inappropriate and actually going to make the situation worse from a clinical aspect. But look at it from the disaster perspective, the much wider perspective. When people panic and they make decisions about hoarding, whatever it may be, it has a direct impact on the response, our availability to be able to respond to a crisis. So it's not something that is welcome, and it's not something that is useful. But what comes next after panic? Well, actually, what comes next is chaos. That's what comes next, is chaos. Now, the difference between a sudden impact and a rising tide disaster is we start from chaos. You think of an earthquake, you think of Kashmir earthquake, 80,000 people dead, 150,000 people injured, 3 million people homeless in the space of 5 minutes. You know, we start from actual chaos. All the things that you expect to be there are gone. All the order, or your house, sometimes your family, sometimes your friends, sometimes the hospital, all the care systems that you would expect to, all the things that you rely on have gone in one instant. So we start from chaos. But in a rising tide disaster, we end up in chaos. And that chaos can have a big impact on our ability to be able to respond. In particular, our impacts on our ability to make decisions. That's not just you and me. That's not just our healthcare systems, our healthcare teams, our governments, even globally. It impacts on us because what we see in certain impact disasters is a big psychological impact on the population following a sudden impact disaster. What people don't realize is that a rising tide disaster has the same effect. It's just gradual. So what is very real is this psychological impact that as we go through novelty, concern, anxiety, panic, into chaos, that then starts to impact on our ability to be able to respond because it directly impacts on our decision making. So we really have to understand that it might have started differently, but we've ended up in the same place. What we have to do is we have to actually take people back to anxiety because chaos is no good for anyone. And the role of responding to disasters is to effectively try to create order out of chaos. That's principally, in a nutshell, what is the role of responders to international disasters. Panic is not helpful, as we've talked about. It has a direct impact on the response, particularly with the hoarding, misappropriate use of drugs, and so on and so forth. But actually what we want to take people back to is anxiety. Why do we want to take people back to anxiety? Well, anxiety is a natural response. It's something that we all do. We all feel anxious at times. It's actually an evolutionary tactic that has allowed us to survive over the last few million years. The reason for that is that anxiety is required because it effectively is the process that allows us to make a decision. And that decision is really about fight and flight. Are we going to sit here and fight this, or are we going to run away? And sometimes what we mean by run away is not physically run away, we mean internally run away, what we call internal fog, where it's so overwhelming that we can no longer respond. And we effectively retreat into ourselves. That's not where we need people to be. Anxiety that is disordered is a disorder. Anxiety that is ordered is exactly what we want. And the reason we want that is because we want people to be in the right place to respond. We want them to be on point. We want them to be in the room. We want them to be now with us, the rest of us. We don't want them panicking. We don't want chaos. And we don't want people that are not interested. We want people that recognize what's going on and recognize that where we all need to be if we're going to be able to respond to a crisis. And what that last line points out, you have to take control of yourself and the crisis. It's vitally important that you cannot take control of the crisis if we cannot take control of ourselves first. Always remember that confusion has its cost. It's very, very real. As discussed from a clinical perspective, there are people that are self-medicating now through confusion, which are adding to their own clinical outcomes. They're diminishing their clinical outcome, which is purely based on the confusion that exists. That's normal. We do see confusion. It's very much associated with panic, but it has a cost, and it's worth always remembering that it has a cost. So part of our role of disaster response is to simplify things. It's to try to remove confusion, whether it be in clinical guidelines, whether it be in our response. And we've seen that particularly over the last few weeks in the Indian response, with just the amount of people responding and the level of confusion between that type of response. The virus in itself does not trade in anxiety, panic, or confusion. Only we do. It's a human problem. So why do we need to lead? Well, leadership is really, really important. And the reason it's important is because it fundamentally covers off a number of areas. We have to maintain safety. Whatever we do, we have to do it safely. And we have to place the patient in the center of what we're trying to do, but also everyone else around us. It allows us to achieve our aims. It's much easier to achieve our aims if we're being led in the right direction. It avoids confusion, as we said. It reduces confusion. So it, again, adds to the efficiency of our response. It increases the efficiency in decision-making and problem solving because we have a process in place. We have someone that's going to make a decision. We can support that process. And it provides support and trust to all of us that will find ourselves in very, very difficult situations. There is never a response to a disaster where there isn't a difficult environment. We teach in disaster response, the first thing we teach is that you cannot cure a disaster. It's the nature of what you're dealing with. You cannot cure it. You have to accept that from the beginning, because if you don't accept that, you're going to find yourself in a very difficult place on a personal level. You're going to place far too much pressure on yourself. So we have to have leaders that will allow us to provide support and trust throughout our response. It's an optimal use of resources. You know, we've talked about the hoarding of drugs and equipment, and that is a direct evidence of why leadership is important, because it allows us to target those resources to where they're actually needed. And of course, everyone is leading themselves at the moment, not necessarily being led in the right direction. And that's to be expected in the panic phase of a rising tide disaster. And if all those things are true, if all those things make sense, then we have a moral responsibility. Not just in some countries, there's even a legal responsibility. Like in the UK, we have the Civil Contingencies Act. So we are actually bound legally within the pre-hospital fields, within the fire service fields, the fields that I've worked in. We have to follow this by law. But there's a moral responsibility to get these things right and lead properly, because essentially it will produce the best outcome that we can guarantee, even though we cannot guarantee or cure anything. All we can do is work collectively together, and it's a moral responsibility that we follow leaders. So what is leadership? There's often talked about, there's often lots of descriptions about leadership, but leadership really is an attitude assumed by the unrestricted. People that do not place restrictions or limitations on the way that they respond themselves. And they are committed to achieving that goal, and they have conviction. That conviction they manage to transmit to others through enthusiasm, optimism, and trust. And trust is vitally important in disaster response and crisis management. Trust is vitally important. Your team, the people around you, have to trust that we're all pulling in the right direction. We're all trying to do the same thing. We're all trying to reach that common goal. But the most important aspect of leadership is while always serving. It is a privilege to be a leader. It is a privilege to be in that position. But that privilege is because you are a servant to the rest of us. Followership. It's really important that you understand you can only lead if others make a conscious decision to follow. I've seen many good leaders, many people that think they're good leaders, but nobody around them is following, and it's absolutely pointless. You have to recognize that you have to build that followership around you. So how do we do it? Well, we apply critical thinking. Now, that might seem quite sensible. I'm speaking to a group of anaesthetists, highly qualified clinicians, and I would expect every one of you to understand critical thinking to a point. But we also have to be honest about critical thinking about ourselves. If we think about it, much of our thinking left to itself is biased, it's distorted, it's partial, it's uninformed, it's downright prejudice at times. It's the nature of human society. Yet the very quality of our existence or our aims that we're trying to achieve in disaster response depends precisely on the quality of our thought. Excellence must be systematically created. Excellence in thinking is vital, and all of us just responding to this event are in that position. And a good example is that clinical discussion that you just had. It's clinicians coming together to try to find the route through. What's the route? What's the right route through? What's the excellence in our response in this as clinicians? What do we need to achieve? What do we need to stop doing? We rely on emotional intelligence literally in the disaster response field. It's very, very important when we teach disaster response. We concentrate a lot on emotional intelligence. And the reason we do that is because fundamentally, emotional intelligence is the tool that allows us as individuals to take ourselves from being followers to leaders. That's what emotional intelligence allows us to do. Emotional intelligence is made up of certain things: self-awareness, understanding your impact, particularly as a leader, particularly within that environment that you find yourself in. And some of you are going to find yourself in some very, very difficult environments. If we go back to and talk about anxiety and panic, some of your colleagues around you will be under that pressure. They will all be in different spaces. Your job in that situation is to recognize that just the very presence, your very presence, has an impact on other people. And as a leader, in particular in leadership, you need to understand that impact and you need to control it. And that's what self-regulation is. It's ability to control and redirect, to think before acting. Don't act just spontaneously. You have to think about what you're trying to do, how you're going to come across. Does it meet your aims? Are you adding to this problem, or are you curing this problem in the sense that you're part of the solution? Motivation. Motivation is so important. People have to recognize that you're motivated for the right reasons. As a leader, you have to demonstrate your motivation for the right reasons. It's not about money. It's not about status. You know, I tell this to every single person I've ever taught disaster response to. There is no such thing as an expert in disaster response. It's the nature of a disaster. It's the worst crisis we can ever face. If I'd have told you last year that 3,226,000 people would already have died as of yesterday from this pandemic, most of you before this pandemic started would not have believed me. This is the greatest crisis that humanity has ever faced within the last 100 years. If you think of the Boxing Day tsunami, 250,000 people, Haiti, 250,000 people estimated to have died. We're way past those figures now. And this has not stopped, and it will not stop until we gain herd immunity, either through vaccinations or we become effectively all have been infected. Motivation is vitally important that people around you understand your motivation as a leader. If you want to lead other people and you want them to follow, they have to be convinced by your motivation. We have to have empathy. We have to be able to put ourselves in the place of those other people and understand the emotional impact felt by others. That includes our friends and colleagues, not just our patients. Many of our colleagues will find themselves in very, very difficult scenarios. You know, and we've known this, particularly over the last year, where we've had to rush people in, medical students, junior doctors, rush them in to take care of patients where they would never have been expected to do so. Nurses looking after multiple patients where they would have been on a one-to-one basis in ITU previously, or 1-to-2 basis, looking after sometimes up to 16, 17 patients, 18 patients. It's horrendous what we've been asking people to do. And we have to understand that emotional impact it has on them. And then the way that emotional impact will affect their decision making. If we're going to lead, we have to lead from the front. We have to lead everyone. Empathy is entirely appropriate and important to understand and apply in all leadership decisions. And you have to develop your social skills, really particularly in managing relationships, finding common ground and building rapport. Partnership working is the only way we deal with major international crisis. We can't do it alone. There's no such thing as a single expert. We have to do it collectively. So we have to build these relationships. And these relationships may not have existed under normal processes. You may not have had to speak to various other people outside your department in your normal day-to-day job. But in this circumstances and under a crisis in a disaster, you are going to be placed into very much wider areas and very difficult positions, and you have to create those relationships, even if sometimes instantly on the ground. Literally in front of you, you have to create. This question often comes up, and it's a point we often make, which is consider leading yourself first. If you want to lead other people, consider leading yourself. Are you actually leading yourself? Know yourself. Know your value. Know your self-worth. Know your vision. Understand what you're trying to achieve. Know the path that you're on. Look in front of you. Are you actually doing what you set out to do, what you believe you should be doing? Know yourself inside out. Recognize your own weaknesses, your own strengths. There's nothing wrong with having weaknesses. Nobody is perfect. There's no such thing as perfection. It's a theoretical concept. It's not a reality. The universe in itself is not perfect. It's the way of the universe. Know where you are right now, where you find yourself, the surroundings you find yourself in, and the complications that you find yourself in. Try to really understand that, but recognize how strong you are. Everything that's ever been achieved has been achieved by us. The human brain is the most powerful object yet discovered in the universe. We are capable of so much. If we remove all those restrictions and limitations of our thinking and apply excellence in thought, understand leadership, we can do things. We can really achieve things. Let your presence speak for itself. You don't need to tell everyone how good you are. Let your presence expect. It will speak for you. If you set yourself out and you set yourself out right, it will speak for itself. So how do we do it? How do we actually manage a crisis, an international disaster response? How do we do it? It's called integrated crisis management. And it has to be integrated because, as I said, nobody can do it on their own. So we have to manage this together. And we have to create an agile response. And what we mean by that is that all parts, everyone, has to be brought into the now. There's no point in trying to manage a disaster and thinking what will happen in 2 weeks' time, and I've got a plan, what I'm going to do in 2. It's happening now. It's actually happening right in front of you. That's what a crisis is. That's what a disaster is. And this crisis is the worst type of crisis that we've ever faced because it's not stopping. It's not like a one-off event. It's not like a tsunami where everyone in the affected zone, or the earthquake where everyone in the affected zone is affected, but everyone outside isn't. This is spreading and spreading and spreading. So it's a large-scale crisis that's literally going to affect all of us. And it has already affected all of us already. But we have to bring you into the now. We have to produce an agile response. So how do we do that? What does that actually mean? Well, we have to have sustainable leadership. What we mean by that is that leadership which is constant. I can't lead for 9 to 5 and then switch off and go off home for the weekend. And then hopefully when I come back on Monday, things will be sorted. It doesn't happen in a crisis. There are no weekends off in a crisis. When we respond to an international disaster, we don't sit there and think, I'll work for 5 days and I'll have 2 days off. It doesn't work that way. We have to have sustainable leadership throughout. We have to have clear, shared collective aims. We have to be really clear that they are collective. We're all trying to pull in the same direction, trying to do the same thing. And we have to remove the boundaries. So if you think of a normal organization, say healthcare is a good example. The NHS is no different than the Indian healthcare system in many aspects. We run, most of our healthcare system has an emergency part of it, a front end of the healthcare system, the NHS, but the rest of it actually runs much slower. There's much more boundaries in between it. You know, I know that anaesthetists will work very closely with surgeons, but they won't necessarily work with many other clinicians because that's not their area of expertise. So those boundaries exist. We have to remove those boundaries. We have, in real time, in the now, we have to take them away. We have to remove the space between us. So whereas I might have been over there, now I need to be with you. I need to be in the same room with you, physically sometimes. Sometimes a good example would bring in proning teams. People that wouldn't necessarily work directly with anaesthetists now have to work directly with anaesthetists. And some of them could be clinically qualified, some of them would just be volunteers. But we wouldn't normally do that. We have to remove that space between them to get people to work in the now. We have to remove the time it takes to get things done. You think about your normal healthcare system, you might have to put a letter, you might have to write something on an email to get something done, you might have to wait for a response. You don't have the luxury of that in a crisis. When we're talking about international disaster and at that level of crisis and integrated crisis management, all of those things have to be removed. Remove the boundaries, the space, and the time. We have to remove duplication. Though we do not have the luxury of duplication in a crisis response. We have to remove it. We can't be doing things twice when we only need to do them once. And we have to reprioritize to match the event pace. Now, this is vitally important you understand this phrase, event pace. Event pace is the nature of the disaster that you're dealing with. In this case, a pandemic. So the event pace is not being dictated by us, it's being dictated by the spread of the virus. So unless we get in front of the spread of that virus, this crisis will continue. The only way we'll get in front of that virus, the spread of the event pace in front of the virus, is that we either stop the virus through vaccinations, or essentially we work together to try and affect herd immunity, and we try to reduce the spread of the virus. That's the only way we're going to get in front of the event pace. There's no point in thinking about something which is going to come and work in 3 weeks' time if the drugs that you're bringing on board or the vaccinations you've got on board are too late. India is a good example of that right now. Vaccination, in a sense, absolutely required, but the spread, the crisis phase is being dictated by the spread of the virus in India and then across the subcontinent, not by anyone else. And it has to be function over form, always. We don't have the luxury of all getting together and inventing a new organization in the middle of a crisis to decide who's going to be the chair and who's going to be on the board. It has to be function over form. If you see something that works, you see good example again is proning teams. You see something that works on the ground in your anesthetic room, that function of proning teams and bringing people together, that's what has to be formed then. But it's the function first that was required. We interjected from a clinical perspective and introduced proning in a way we've never done it before. That becomes the function. The form of bringing the teams together follows that need for that function. And that always has to be the case in integrated crisis management. So there's a methodology that we use. It's called the 8R method. If you think about turning up to a disaster in the middle of it, and you're all being faced, as you are now, with having to make some really tough decisions and find a way through this, create order out of chaos, how do we do it? Well, simplicity is the key in disasters, as it is in most things, but actually more so in disasters because we don't have the luxury of complexity. So we follow this simple method. So what does it look like? Well, the first one is redefine. You have to question the question. What is your aim? What are you trying to achieve? What is the remit that you've been given? And what are you trying to achieve? You have to question the question. I've seen so many good efforts wasted because the aim was the wrong aim, not because people didn't work hard, they just were following the wrong path. So we have to question the question. That sets out the aim that we're trying to achieve. We have to reprioritize, reset our objectives. If our objectives are not meeting the aim, then why are we doing them? We have to identify what are the priority things that we have to now do to deliver our aim. In many cases, a good example would be understanding the right treatments for patients in ITU. As anaesthetists under this pandemic, because it's a respiratory pandemic, you are at the forefront. You're absolutely in the room. Everything that's going on is going on, and for those acute patients are going on around you. So we have to prioritize what are the things that we actually have to do, and what are the procedures that will work? How are we going to get to that understanding? So reprioritize and reset your objectives based on your overall aim. We have to remove. We have to stop doing the unnecessary. Just stop it. There's no space, there's no luxury in crisis response for doing something which does not add to the aim. If it's not delivering your aims, it's not part of your objectives, just stop doing it, remove it. We have to repurpose. And this is all the resources that we have. Every single person that's available to us, every single thing that's available to us, we have to think about it again. What can it do? Again, examples are drugs that we might not have used before, that we've used for other things, that we've now had to repurpose, bring into line because they have an effect. But also people that might be asked to do something they've never done before. They might have turned up to you and been qualified to do something else, but you're asking them to do something else. You have to repurpose everyone that's involved in this. And one of the things I would get you to remind you of is ask people to do what they're good at. Okay, don't ask them to do things they're not good at. So if you've got a choice, get people to do things that they already are good at. Because if everyone can do things that they're good at, pretty quickly you'll realize actually your response is getting better. You have to re-energize. And that's really about empowerment, the whole team, including yourselves. I'm sure some of you have found yourselves in some very difficult situations in your units where you're having to deal with numbers of patients you've never had to deal with before. You're having to deal with a level of death which you've never had to deal with before. The effects of that are terrible on all of us. We have to re-energize the people around us, including ourselves, to actually get ourselves back on point. Recognize that there is going to be time for more, but actually right now we have to respond. And that's the most important aspect, respond. we have to act. Having put those things in place, we have to act. And speed trumps perfection. Michael Ryan, the head of the WHO mission for Ebola, was asked this question: what was the one lesson you learned from Ebola? His answer was absolutely clear: speed trumps perfection in all cases. There is no point in trying to wait for a perfect answer. You have to act. You have to act now. Sometimes when you act, you only know whether it's right or wrong once you've acted. So you have to review straight away. You have to review what's going on. And that review is all, these processes are universal, but all depending on the circumstances you find yourself. If you're entering, good example again would be the discussion about patients being prone and recognizing that actually sometimes it doesn't improve. It doesn't improve their respiratory rates. It doesn't improve their oxygen saturations. And we have to review that really quickly to understand, is this the normal process that we expect? Give time for it to work? Or is this something else? Is this patient not capable of taking prone? We have to review the moment we've responded. And then the last one is just repeat. We just start again. We go back to the top. We redefine. Is our aim still our aim? Our objectives still our objectives? Have we actually removed everything? Have we repurposed what we can? Is there other things that we can repurpose? Did I spend time re-energizing what I needed to re-energize to make sure that we can actually respond appropriately? Have we actually responded? Can we continuously make sure that we review? Are we doing that appropriately? And just keep repeating the 8R method. And that's how we deal with disaster response. To try to get order out of chaos, we go through this process naturally. And we just keep doing it and keep doing it. And it will get better in a sense in a normal disaster, in a sudden impact disaster, because more resources come online, more people come online, more organizations come online, and we can start to make sense of some of the things we're dealing with. In a pandemic, a rising type disaster, the worst type of a disaster, that challenge remains throughout. It continues, in a sense, to challenge us until this thing is over. So we have to go through the process of the method again. It's a continuous flow. And the speed of that repeat is down to the circumstances you find yourself in. So if you're a good example, again, would be the discussion about whether a patient is appropriate in proning and whether that patient, we need to give that patient time. So we give that patient time, but we continuously question, continuously go through the process again, continuously question, oh, is the aim for this patient right? Have we got our priorities right? Is there something we can remove? Have we got all the repurposing right? Does everyone understand what we're trying to achieve? Are they re-energized? Just keep going through the process constantly until you get through it, which is essentially what the 8R method allows us to do. You think about a disaster, an earthquake, a tsunami, we can't just turn up and all start doing our own thing. We have to be aligned. So we try to follow this method that allows us all to be aligned in our actions, in our response. You have to build a cohesive team, a team around you. As I said, nobody is an expert in disaster. Someone tells you they're an expert in disaster, even me, be afraid, okay? Because there's no such thing as an expert in a disaster. So we have to build a team. So what does a cohesive team really look like? Well, they have to have an identity in a sense. They have to know what they're there for. Sometimes we use labels to do that, but actually they have to have that identity. They have to know. Again, good examples of proning teams. You know, proning teams have worked very well in the UK, and bringing people that were not clinically qualified together, giving them a label, making them understand what their objectives were, showed how quickly you can build a cohesive team. People have to be flexible in their roles. No longer can you say, I'm only an anaesthetist. That's all I do. I'm just do anesthetics. You know, if something needs to be done, it needs to be done. And we don't wait until we're told in disaster response. That's not what happens. We have to be flexible. We're all part of it. And that comes to situational awareness. We're talking about whole team situational awareness. Understanding where you are, understanding the implications of where you are. Situational awareness is a skill set. Often the people that are best at situations are pre-hospital clinicians, because they're having to deal with it in dynamic environments. So they have to understand the environment they're in. And they also have to understand if they act, what will happen, and if they don't act, what will happen. And that's what situational awareness is. In a team, you need shared situational awareness. Everyone is part of the understanding the environment. 10 pairs of eyes are better than one. You might have somebody leading, but everyone's input is valid. Everyone's input is valid, and everyone's input is valuable. So we have to make sure that we have a shared situational awareness. And we have to have shared knowledge. If we've got tactics that work, If we've got things that we know that will work and actions that we will have to share that knowledge. There's no point in holding it to yourself. And I've seen this time and time again where people come up and go, I thought about that. Well, why didn't you share it? Why didn't you share it then? When you thought about it, why didn't you share it? Because that shared knowledge can make such a difference to the team output. So you have to build a cohesive team. And it might just be you with one other. It might be you with 20 people. It might be your hospital. It might be your healthcare system. It might be your government. You have to build a cohesive response. And that is built by making cohesive teams. Integrated crisis management, there are a number of things that we want you to think about constantly in the background of what you're doing. If you're not sure of your aim, just remember our aim ultimately in healthcare is to save life, render humanitarian assistance, and most importantly, promote recovery, to get back to order. You know, there are lots of patients that are suffering because of COVID, but there's many more that are suffering because their healthcare system is under pressure. Their treatment has been cancelled, delayed, their screenings. We knew right from the beginning that that mortality peak was likely to be higher than just from COVID itself, purely because of the focus on COVID. So we have to promote recovery in everything we do. You have to be part of that promotion of recovery. We have to anticipate. What do we know? What don't we know? What's coming around that corner? Let's not wait till it hits us. Let's think about that now. Let's think about what's coming around that corner. I mean, many people will argue that some of the things that are happening right now, we could have seen quite reasonably a year ago. But we took our eye off the ball in many cases, not just in India, in the UK, prime examples of it, people becoming complacent, politicians and governments becoming complacent and thinking, we've done this. We haven't. We have to see what's coming around that corner, and we're still in that position. Complex versus complicated. It's a really simple equation. If you've got complex and complicated working against each other, you're likely to be resulting in unachievable. It's not going to work. There's no room for complicated in a complex environment. There is nothing more complex than a crisis, nothing at all. So applying complicated solutions to a complex environment is likely to result in unachievable. So you can flip that equation around. If something's not working, it's likely that you've got complex and complicated working against each other. Most of the time, you cannot change the complex environment. It takes a long time to change a complex environment, a lot of effort required to do it, but you can change a complicated solution. Simplicity is the key. We have to stabilize where we are when we're faced with a crisis, but actually what our main role is to go beyond stabilization and create positive pressure. We have to push out. We have to push out from where we are. If every one of us takes on the responsibility of managing crisis and follows it in a methodology, follows it in a systematic way, we can start to connect. We can start to connect across our teams, our hospitals, our healthcare system, our countries, even our families. We can start to connect to create positive pressure. Once that positive pressure connects, very soon we're starting to change. We're moving from a reactive phase to a proactive response, and that's what we need to be. Preparation is never too late to learn. Don't assume because we've been caught essentially on the hop that we can't prepare. We can prepare. We can prepare for what's coming. If we're looking around that corner and we can see what's coming, we can start to prepare now. Even in the middle of a crisis, we can start to think differently about what are we going to need to do in a month's time, in a week's time, in 6 months' time. How do we need to think differently now and start to prepare ourselves? A good example is the countries that are surrounding India right now, Nepal, Bangladesh, Pakistan. They will become engulfed. It is obvious to see. The first cases of the Indian variant have been reported in Brazil today. It's obvious to see what's going to happen. We have to start to prepare. Be kind. This is absolutely important. There are times in crisis response, and you will find this, and some of you unfortunately probably have already found this out yourself. There are times when there is nothing else left. There's nothing we can do. They're beyond our clinical intervention. We cannot help them. But the last thing that we can do for everyone, and the first thing that we can do for everyone, is to be kind to all, not just our patients, ourselves. Take the pressure that we're applying to ourselves and make sure that we're all interacting in the right way. Believe me when I tell you this, I've been in situations where being kind was the only option available. There was nothing else left. And it's horrendous to be in those situations, and some of you have already found yourself in a situation, but it's vitally important, particularly as clinicians, that we don't forget to be kind. We treat people as people, and not numbers. 3,246,000 people have already died. Every one of them is not a number. They are a brother, sister, son, daughter, mother, father. Every one of them. Every one of them will have an effect on a much wider effect than just the loss of those people. So we have to be kind. And it's not over until it's over. There's no time to relax. You have to find times to look after yourself. And that's what we mean by sustainable leadership, that you can transfer leadership across, keep the leadership running, but make sure that nobody can do it all on their own. But it's not over till it's over. This pandemic will not be over until it's over. Initial reports and historic reports of the 1918 pandemic said it lasted 3 years. We are in a different position because of the way we responded, because of vaccinations. We're not sure how long it's going to last. It may be extended because of the effectiveness of some of our actions. It may be shortened because of the effectiveness of our vaccine. Our vaccines may prove fatal in the sense of overconfidence in them because of the variants and the hybrids that the very rapid spread is causing. It's not over until it's over. So we need everyone still in the room, everyone in the now, as part of integrated crisis management until it's actually over. I'm just going to read this because I think it's important. This panel's report said the situation was made worse by delays in relaying information to the public, managers' lack of knowledge of procedures to deal with emergencies, poor communications between the workers and the government, amongst the workers themselves, and amongst the government bodies. That was the conclusion of the Fukushima nuclear disaster. It's not that actions could not have been taken. It's that other factors resulted in that disaster. They knew what the problem was right from the beginning, but the nature of the interaction between particularly authorities, waiting for someone to give you the authority to act, caused the disaster, led directly to the disaster actually melting down and the Fukushima nuclear disaster. You cannot wait in crisis management to be told what to do. You have to create these leadership on the ground. You have to take control of crisis management in an integrated way yourself. You are all part of the response. Nobody is more valid than anyone else. All are valuable, all are valid. You have to take this on. Don't wait to be told. Do what you can with what you have, where you are. Theodore Roosevelt. And it's absolutely right. You do what's in front of you. Where you are, where you find yourself, whether you be in an ICU unit or whether you be in an ED department, whether you be managing patients, you have to do what you can with what you have where you are. You can't wish for things that cannot be delivered. Chaos is defeated by the application of uniform positive pressure, all of us applying positive pressure in a systematic way to actually overcome the chaos of a disaster. And no one, do your best. No one can ask any more of you, including me. I can't ask any more of you. Just do your best. Look yourself in the face at the end of this and do not be found wanting. Because many of us will have tough decisions to make, very tough decisions, particularly when it comes to rationalization of care. But if we do our best, nobody can expect any more of us. Nobody. I show this picture because you can achieve anything. This is me about to be told in 2005 by a flight sergeant for an fully armed American Chinook that came across from Afghanistan that they were going to fly back to Afghanistan. 20 minutes later, they took 42 patients to Rawalpindi because I had a conversation with this flight sergeant. I made him stand in the middle of what he was looking where we were, and I asked him to look around and really tell me what was going on. And then I asked him to break his orders, and he did so. Anything can be done. Anything can be achieved if you take responsibility and you lead. Anything. That's the end of my session. I'm happy to answer questions. I try to keep it brief.
Thank you. Thank you, Dominic. That was such an interesting talk, very timely. And I'm sure, a lot of what you've actually said has resonated with what we are actually feeling and what we have actually seen. And I think, as you rightly said, all we can say is positive. I'll ask you two questions, if you don't mind, Dominic. One has to do with aggression, and especially the aggression of the patients. What a lot of doctors in India have realized is suddenly, when you're in a situation which is quite hopeless and people are not being treated, people tend to be aggressive towards the doctors, and a lot of people are finding themselves in this situation. I mean, do you have any tips of how the doctors can deal with this? That's my first question. My second question is, I know you're in contact with government, and I think I think this is the most unenviable time for any government or any prime minister, because on one side they have to balance the impact on the economy, and the other side they have to balance lives. And we know if the economy goes down, lives will be lost. And in a country like India, where a lot of people are like hand to mouth, poverty is a main factor. Trying to get people to participate in any kind of positive initiative sometimes just goes down the drain. And that's the reason I see that there is no country which has not had its share of problem, and ultimately everyone's blaming the country's politicians, where I don't think so they could have done anything more than that. What are your thoughts on that?
Well, let me ask the first one about aggression, because I think that's really important. And I think it is something that is you're seeing a lot of in India and across the subcontinent, because people are finding themselves in that space where they're in panic, and they recognise that actually the systems that we thought were there are not there; they're not working, and that's leading directly to death and loss. That's a very, very difficult scenario. Wherever I faced it in the past, the way I try to deal with it is to make that connection with people, is to make people understand that we are doing our best under such difficult circumstances, and we're trying to get people to understand that just because it's difficult circumstances does not mean that we will not do our best. We will do our best. You cannot eliminate it. It is impossible to eliminate, and it is unfortunately different in many cultures, but it's existed here as much as it exists anywhere else. So reality is the only way that you can deal with it is on a one-to-one basis, on the people that you're dealing with in front of you. I'd love to be able to wave a wand and say we can remove aggression from this response. The only way I've managed to do it in the past is to have that really honest conversation with people that are in front of me, that are actually displaying that aggression now. What I would say is one of the most common mistakes in dealing with aggression is aggression. Two people shouting at each other does not solve an issue. I have a very good colleague who's a consultant surgeon at the Royal Marsden, Shanwaz Rashid, and he practices this daily. When a patient or a patient's relative start shouting, he gets quieter. He gets quieter to the point of where they start to have to listen, because they realize they're the only one shouting. They're the only one that's being aggressive, and it's not getting anywhere. But two people shouting, it just exacerbates itself and just adds to itself. There are no magic answers when it comes to this. It is unfortunately the nature of crisis, and particularly international disaster response. And when I say this, when we say teach people from the beginning that you cannot cure a disaster, you cannot save everyone. It is unfortunate you cannot save everyone. Do not take that pressure on yourself. Do your absolute best, as I know you are as clinicians. I've heard the clinical discussion. You're doing your best under really difficult circumstances. Nobody can expect any more of you. Even the patients can't expect any more of you. But we have to try to empathise with the patients. We have to try to see it from their perspective and try to talk to them in a way which recognises that. One of the things that we teach in disaster response, which is quite strange, you wouldn't think we'd have to teach this, is that when we do we do modular exercises. So we give clinician teams, we put them together and we give them patients. One of the things we have to correct on the very first exercise we ever do is, did you know your patient's name? Did you speak to your patient as a person? And you'll be surprised how quickly under chaos, under crisis, people forget the basics. That's why it's really important to be kind. If you're kind, calm, collective, and you're trying to do your best, anyone that is going to be aggressive for you they're in the wrong, not you. But far too many times as clinicians, we think because we're qualified that we can talk to patients in a way which is not helpful. It does not help. It does not help the outcome. We have to think of them as what they are, human beings. We are all human beings first. We have to try to build that relationship with them. Will you be successful in all cases? No. But I can tell you that in many cases I have been successful. And being calm is absolutely clear to that. In the paramedic exams that people take in the ambulance service, if you do not mention the word reassurance, you will fail the exam. It's as simple as that, because it's the most common answer for all of the exams. Reassure the patients. Sometimes that reassurance is at the point of where the only thing you can say is we will do our best to look after them even though they're gone. And I've had to do that in circumstances. But even that reassurance allows people some comfort. So you have to find the ways to deal with that. Your second point, which is a question about governments, you're absolutely right. Nobody was prepared for this. Nobody. No matter how many times people said that they were, the UK government made statements saying we were the most prepared country in the world. We've lost over 100,000 people already in the UK. Many of our clinicians we lost purely because we were not prepared for PPE. You know, it's very, very difficult. India is going to find this as an ongoing and rising issue as it goes forward, just purely because of the numbers that you're facing. Your clinicians are going to be affected, and we will lose people. And it will be many people will pointing fingers and saying, we shouldn't have done that. We should have prepared. We should have had PPE. People should have had PPE. The same conversations occurred in this country. We should have had procedures in place. We should have known what was coming. There's no such thing as perfect. It's crisis management. So you can spend your time pointing fingers at the government. My suggestion would be there will be time for that. There will be time for public inquiries. There'll be time for discussions about that. Is it now? Only if it makes a difference in the now. Only if it gets you what you need now to respond. You know, if you need to make sure that you're getting your resources and you're not getting those resources, and you feel that actually you need to raise your voice to get those resources, that's not invalid. But criticism against anyone doesn't necessarily help. What we want to do is to build relationships at every level in the response, to even between governments. You know, that's one of the reasons why we are going to fail. When we predicted this from the beginning, what we said was there would be 4 main mortality peaks. All of those predictions have come true. We said the first one would be from the virus itself, from COVID. The second one would be from those patients, and likely to be higher, that have had their treatment suspended, cancelled, delayed. The third one will be the economic impact, and that will affect us in the short, medium, and long term. And some countries are better equipped to deal with that, and some countries are more susceptible. India is a good example. It's a very much a day-to-day, hand-to-mouth existence for a lot of people. The economy is vitally important. People getting food and getting resources is vitally important. Of course, social distancing measures and restrictions and lockdowns have a much bigger implication in India than they would do in the UK. But they have implications everywhere. So we need to think about that logically. But the fourth one, and the most disappointing, is the lack of global coordination. We really need to think about this now as a global issue, as a global response. And we really need to target our vaccines to where they're needed. We need to target our resources to where they're needed. And that applies across the board, not just in medical and clinicians and medical outcomes, in health, in food, in water, making sure that people can survive, that people have support through this. We have lost too many people already. We will lose more. What our objective is to lose at least the least amount of people that we can. We have to try to save as many people as we possibly can. We can only do that now together. And my only criticism of governments that I would say is this, is there are individual criticisms which are going to come out in the long run. But right now, the biggest criticism of all the governments is that we are not working together. And we have to work together. There was one family, one planet, everyone is valuable, everyone is valid, no exceptions. We have to base it on clinical outcomes alone. What's the best thing we can possibly achieve based on clinical outcomes? That's why I'm a great believer in letting clinicians take the lead, because we will base it on clinical outcomes, not on any other factor. Does that answer your question?
Yeah. I mean, it does. Thank you. Thank you so much. Shiv, do you have any questions?
No, it is amazing because it has laid a foundation to what I'm going to talk about in my talk. So quite a few things were actually included. There isn't any questions from the audience except for appreciation. They say, "What a wonderful talk." That's all I can actually see in the comment section for you. Dominic.
Well, I'm being perfectly honest when I say this. We are all in this together.
Yeah.
We are all in this together. You know, I see no boundaries between, you know, when we talked about integrated crisis response, remove the boundaries between our countries, between ourselves. We're all struggling with this. There is no single answer. There's no perfect outcome from this now. We have to work together to reduce the impact of this.
Yeah. That is the title of my topic.
So I think Teju, do you have any questions?
I don't think there are any.
I really love the 8 hours thing. I even took a screenshot of that. It's really nice. Very wonderful talk. Thank you very much.
No problem at all.
I think the main thing which I think NHS is crying for, which I think a couple of times you've mentioned, is learn to be lean and learn to be agile. I think these are things from the private sector which we can really do. Anything which doesn't improve the patient outcome is basically a waste. And institute change as you see something is happening, rather than wait for it later on. I think that in this crisis, that was something which we were helped a lot by our trust. Reducing the bureaucracy, instituting changes when you think it was appropriate. And I think we take a lot from your talk, Dominic, today. Thank you so much for being a guest speaker. You've been patiently waiting and listening to all our medical talks. I hope we didn't sort of take a lot of your time. So thank you very much.
No problem. What I would say, I've learned as much from listening to your talks so I take every opportunity to learn. I think we all need to. So, there's something to learn from all of us.
Absolutely.
So
do you want to my talks?
Yes. So I think moving on now, we should move for one of our most motivational speaker.
I don't know whether motivational.
Yeah. So I think I'll request Shiv to talk on this topic on leadership skills to be a COVID warrior. Shiv, the floor is all yours.
Thank you, Dheeraj. So I'm going to talk about Ubuntu in medical care, and it's called Circle Up. Okay. So what does a leader mean to you? I'm going to show you a nice video of kids. What does leader means to a kid? Listen to them. It's very, very interesting. It is a long video, but then it's always pleasure to listen to children. But the last one is the most important one. So you need to actually wait till the end to actually see this. It's not playing. Interesting. It was playing yesterday and now playing now. That's so I'll have to actually go back to that. Crazy. This was a very, very interesting video of children, and so I don't know why it's not playing at all. I actually played it yesterday, but today it's not playing. But in the end,
just play it without your presentation. Play it and then share the screen.
It's actually a link. It might be because I'm actually using YouTube, and this was actually a YouTube link on that. That's why actually I think it's not playing. But ultimately, I will actually tell you, it's fine. Sometimes this happens. I should have downloaded and used it. But basically, children was actually all talking about, what actually leader mean to them. Somebody said it's my teacher, or somebody said it's my president. Somebody said it's myself. So all children are very funny, and they are absolutely, But the last one was a kid who said it's a doctor. So this is interesting. Again, I don't think this video is going to play again. So what exactly is Ubuntu? Okay. So this was again a video about Ubuntu, and basically this was an anthropologist who actually went to Africa, and he was actually doing an experiment with a tribe. And he took this basket of fruits, put it under a tree, and then got these kids and said, okay, run. Whoever actually reaches it first gets the whole basket of these fruits. And these kids, what they did, they just held each other's hand, and that they ran together to the basket and shared the fruits. The man was actually very surprised. He said, you know what? One of you could actually won this contest, and you could have actually, got these fruits, all the fruits for yourself. And the kids say, no, I am because we are. How can I be happy, or how can we be happy when others are not? I'm only happy because we are all happy. Okay, so they actually shared the fruit. So this is called Ubuntu. And this has been mentioned by a lot of people. So Ubuntu is I'm because we are. And I'm going to talk about what is Ubuntu in medical practice and in COVID times. Okay. Now, emotional support for
your screen.
Sorry?
I think your screen has not been shared. So
It's not been shared. Okay. I was just talking to myself then. And let me. Yeah. I'll share it again. So did you all watch this one? See? So you're just talking about the Ubuntu. Okay. So Ubuntu is about I am because we are. So Ubuntu in medical practice and COVID times, I'm going to talk about that and how actually we can be the leaders. So being emotional support for clinicians is not simply a nice thing to do. It is a practical because it supports the clinicians' continued participation in healthcare team rather than calling in sick, quitting, or leaving the profession. Now, this is a statement taken from one of the papers. What says, as doctors, this is not the time when we can just quit. Everybody is being affected. Now, COVID is a disease which has led to a lot of stress, a lot of burnout, and this has caused psychological harm. There are a lot of knowns and unknowns. Knowns like, okay, oxygen has not been available for like what we've been talking about recently. There is limitation of resources. There are no ICU beds. There's no oxygen cylinders. Okay. Then it's about personal safety, about yourself, about your family and your friends. And they're unknown. We don't know about this disease. I don't think we still know. As you actually seen what Teju was saying, there's so many treatments being tried. Some of them said, okay, they work, they don't work. We still actually haven't got all the results. We don't know whether these improvised and untested protocols will work or not on these patients. The patients we want to save, because we become doctors because we want to actually save lives. And this is one situation where people are actually seeing young people dying in front of us. So what can we do? Okay, so on one side, we have this COVID-19 care, and then the other side are the processes, okay, and psychological support. Okay, so what we need to do is enhance the existing pattern of the team, the communication and coordination, okay, and improve processes. Then we need to look at the psychological support. We need to look at psychological well-being of the people. We need to look at the psychological safety of the people. Okay. When we talk about the psychological safety, we're talking about whether people are able to ask for help. Okay. People are being left to work on themselves. Juniors have been left to work on themselves. They may not actually have that support, and that's why we're having these kind of symposium. We had this COVID rounds 2 days ago so that we can answer some of their queries. We have our group where they can post their queries. I have created a support group on Telegram as well. Okay, they're able to speak up. Okay, when they have concerns, are they able to speak up? Okay, and are they able to share their ideas? Then there is about this, well-being of the people. Are they able to contribute to solutions? Okay, they have some idea. Are they able to contribute to solutions? Are they able to learn and share their ideas? And is there peer support available to them? Okay. So leadership involves a lot of things, and we just heard Dominic talk about what exactly leadership is about. Okay. But what I want to stress is that leadership is action. It's not a position. Okay, you just don't become a leader just because you have been put on the top. Okay, it's about actions. Okay, so just because you're a junior in the intensive care does not mean you cannot be a leader. Okay, you can still be a leader. And we need to look at workable and testable solutions. Can you actually put this part of the puzzle into that without actually disturbing the whole configuration? Okay. Solutions need to be inexpensive. They should be easy to implement. and they should be broadly applicable. But unfortunately, COVID itself is complex, it is uncertain, okay, and a lot of dynamic clinical work is required. Things are changing constantly. We find new protocols coming in, people talking this treatment doesn't work that well. And then we have people who actually want to use all kind of treatment. People will be, we talked about aggression just a few minutes ago. Okay, there will be people saying, why this treatment has not been given to my relative, okay, or is the patient going to die? And that brings in the anxiety within the doctors community. Says, oh, what's wrong in actually using this treatment when we don't know whether it works or not? And these relatives are asking that, well, should we be giving this treatment? Why are not you giving this treatment? What will happen if the patient dies? So coming back to Ubuntu and Circle Up, okay, what is this about? Okay. Why am I talking about Ubuntu here? It's because it's about interprofessionals, okay, on the shift. Okay, we're talking about now coming to not what is happening outside, but we're talking about what is happening within your unit. Now you are the leader, okay. How are you going to actually go about making sure that your team is effective, your team is happy, your team is able to achieve their goals? Okay. I briefly talked about psychological well-being, okay? So psychological well-being is achieved when you give opportunities for people to contribute to solutions. Psychological well-being is achieved when you actually have the opportunity to learn and share within the team, and when you're able to support each other. That is, there is a peer support within the teams. Then it's also important to actually create a safe environment, and that is called psychological safety. And as I said, this is about being able to ask questions, able to actually ask for help, and able to share your ideas. The communication is very, very important part of this circle up. The communication need to be timely, it need to be frequent, and it need to focus on problem, okay, on problem solving. It need to actually focus on building mutual respect. It need to focus on clarifying shared goals. Okay, it's a very, very important component of the communication. And again, Dominic touched upon this. It's about actually taking action as quickly as possible. Okay, it may not mean that it is the best thing down. It is about actually giving or acting in a very agile manner. Okay. The other thing about the whole thing is about also having quality feedback. Okay. Because healthcare culture is not static. It's constantly changing. And because it's constantly changing, it's only able to sustain because of the normal micro conversations and actions we're going to take. If we are actually getting, say, a new guideline and you're not able to actually implement it, or you did not get this guideline in time, then there's no point actually of that guideline. So you may not be actually be following the right kind of protocols. So again, communication actually becomes very, very important. So what is this Ubuntu Circle Up I'm talking about? Okay. Now imagine you're actually watching a game of, say, rugby or football. Now, before the game starts, you will actually see the coach actually comes in and then say, guys, come on, circle up. Everybody does that. They actually high-five each other, and then the game starts. Okay, that's what circling up is. They are actually discussing, either they're encouraging themselves or encouraging each other, or they might be actually discussing a very short strategy. So it's not a big, kind of a briefing. Okay, it is a very short briefing, and before they go into the game itself. Okay. So the whole thing is about a circle. Okay, so this is also a symbol of Ubuntu. So it starts with briefing or the huddle, which starts at the morning. If it could be beginning of the day, beginning of the shift, or beginning of an activity. We look at what process we are going to follow, what protocols we are going to follow, who are the people within the team, and we rehearse this sort of mentally. This is not about talking about each and every patient. This is not our rounds. This is just a brief about the whole day activity, how we're going to, behave during the day, or what is our roles are going to be, and what our plans are going to be. And then during the whole day, there have to be micro checks. This should happen throughout the day, and there is your role as a leader. It can be people asking for informal health. So you may not know the answer to a question. Then you might actually post it on our say group, or you might actually call a friend, or you might actually have a group like a WhatsApp group or Telegram group where you can ask for the help. It's about asking about well-being of the people around you. It's a make sure, have you been drinking enough water? Have you had enough breaks? Have you had your lunch? Have you had your tea? Okay. And asking, how can I support you? That is what is micro check. And these need to go frequently through a day. At the end of the day or end of a shift or activity, there need to be a debriefing or a huddle again. Okay. Here is the time where you share your successes. Okay. Not everything can go right. Okay. This is the time we explore the challenges. Okay. Discuss what we did well. That was basically sharing success, but also what could we have done better. Okay. This is the time for actually reflection. There is obviously other things involved as well. There is the implementation. You need to actually talk about team and their visions, and you need support. You need support not only from your colleagues. You need support from the external, managers, the chief executives, the clinical directors, the unit directors. Okay. Then there need to be schedules. There might be activity meetings, and there will be about the talks about the inflow of patients. Who are we going to admit? Are we going to triage? How are we going to discharge? Where are they going to be discharged? Are the resources available to us? Those are part of the schedule. Then there is also part of training, workshop and coaching. And this has been mentioned again and again, is about the proning teams. We did it as well in our hospital. So we actually had the surgeons, we had whoever was free at that time to come, porters, everybody. And we used to actually hold. So we had lots of theaters which are actually empty. And one of the theater was converted into a kind of a scenario room. Okay. So we used to actually have a mannequin, and who's going to lead the thing, and we used to go through the whole process. So the workshop and coaching should be going side by side. Okay. And then again, there is execution refinement. Okay. So you go back and check again and again, what are we doing right? Where are we missing out? How we can improve? And this is the whole part of the circle up. So to just sum up, I did not want to go too much into details. This is last part of the lecture. We need to remain positive. Okay. So Ubuntu Circle is about improving the processes and psychological support. Okay. Improving processes, there are only two important things in that. And that process is about communication and coordination. Okay. Everybody says, so CNC, you communicate everything. Wherever communication fails, there are disasters going to happen. It's about coordination, and that's you decide in the morning. Okay. It doesn't matter if you're not deciding in the morning, you can always have the checks in between. Okay. So the micro checks is a time when you can again refine your things. So briefing and debriefing is about team connections and setting up the tone for the day, or for the shift, or for the activity. Whereas the micro checks is about reinforcing the components of the brief and debrief. So at any point, you can go back and actually check, all right, are we doing fine? Are we okay? But it's not only about reinforcing the components of briefing and debriefing, it is also about asking about the well-being of your team members. Have they had their hydration, they are able to get their drinks, they are able to get their food, they are able to get some amount of rest. Okay, that is very, very important. And the last thing, the situational overview, plan for the shift and the team communication. This has effects on both individuals and patient care. So if you're able to communicate properly, if you're able to actually support your team psychologically, okay, you're able to actually provide them a psychologically safe environment, we are going to actually have a better individual, well-being, that is your staff well-being. At the same time, you will actually ensure that the patient outcomes are actually better. Okay. So, like I said, we actually have our group, the anesthetists. We have 29,000 members, more than 29,000 members, where you can pose your queries. And we actually have also created a anesthesia support group where you can actually discuss about your personal thing, which is non-clinical part of that, and that can also be discussed on the support group on Telegram. So Telegrams allows us to actually have a lot more people. Okay, and thank you guys for listening to me. I'll try to keep it short and sweet, and I'm happy to take any questions.
Thank you, Shiv. That was again a fantastic presentation. I mean, I think
my videos didn't work. I thought I would actually make it a little bit more entertaining with a video, especially the kids. I think those 5-minute kids videos are actually amazing. Thinking of what exactly leader, what children actually think. That's always, I think.
It's wonderful, isn't it? Children are sort of pure, unadulterated, just speak what is there in their mind, and then they come up with sometimes very, very simple solutions to very complex situations. I think as adults, sometimes we overthink, we overdo things. And I think, this thing, your talk and Dominic's talk should provide some reassurance to all the doctors who are, especially the junior doctors who are working. It's all about empowerment, isn't it? I mean, there's a word which they call about, they say, finding your ikigai, it's just your reason for being. And I think at this point, as doctors, I think you are passionate about you're finding that passion in your vocation, you're being paid for that, and you're finding means to live with that. And at the same time, it is what the world needs at present. So sometimes you might feel, because of the nature of the disease, that what I'm doing doesn't work, but no, you are making a difference, and it is very important. And just making sure that you are in that frame of mind. And as Shiv rightly pointed out, I think sometimes it's important for colleagues to look after each other. If there are 2 junior doctors on the floor, one can look after the other. It doesn't matter if you're consultant somewhere else and doing something else, you can look after each other. So Shiv, one of the questions I want to ask was, we got a few junior doctors who feel very unsupported, and they feel unsupported because plainly there's no one senior around sometimes to answer their questions, but at the same time they are worried with what they can do. If you do something and something happens to the patient, then they worry that they'll be blamed for. In this kind of scenario, what do they do?
Yeah, I think it's very, very important. That's why I said able to speak up, providing them a psychological safe environment is very, very important. I think that's not been provided to them. It is where they should be able to actually ask for help. One, second thing, are able to speak up, and third thing is to share ideas. These 3 things are the main component of providing a safe environment for them. It's very, very important. And so, even if they're not able to actually get that kind of thing, the thing is that the protocols, that's a communication and coordination, is very, very important. They need to actually know. The least they can actually do is, okay, fine, you don't want to come to the intensive care, that's okay, you stay outside. You tell me which protocols I need to follow. That need to be very clear. I think that should be released at the department level. Or you can actually see that there are actually protocols being provided by institutions like London Institute of Medical Sciences. So that's one thing. The second thing, like we have talked, the reason why we actually having this symposium are that they do not know how to institute, say, NIV, non-invasive ventilation, when to put patient non-invasive ventilation, or what ventilation modes they need to actually use. And that is support we can also provide. Even if they're not getting that, we can actually provide it on the group, or we can actually provide an individual level as well. Some people actually might not be comfortable asking that. They can put it as a general question on the group. So that we can actually provide. But I think it is important that these people are able to speak up. Now, what's the barrier here, I think, is that some of these senior people who are there are also on the group, and the juniors are unable to actually speak up. And that is one of the biggest barriers we are actually facing.
Yeah. It's a very interesting point you make about guidelines. I think the inherent problems is that, one, people who are certainly high up keep all their knowledge to themselves. One of the things I think, if you look traditionally, Indians never published any papers. We were doing things years ago before people started publishing, but what we were not good at was publishing. Even if you go on to Vedic culture, the person who was the leader always used to whisper the secrets to his favorite disciple and not write anything. And if that favorite disciple died, the whole knowledge which was there was died. And suddenly there is, sometimes when you talk about guidelines and protocols, people say, oh, why do I need it? I know what to do. But I think guidelines are there to protect the weakest, and it empowers everyone. So if you actually have something written there and everyone has agreed to follow it, you are never going to be criticized for something which has been agreed by the department. So I think that is a very important point you make, Shiv, that if people can't be around, at least they need to make sure that there is some set of guidelines or procedures, some protocols for people to follow, isn't it?
I think it's unfortunate that some of the juniors have been left on their own to deal with it. And I'm not saying that it is wrong that the seniors don't want to expose themselves, as some of them might be actually be in a vulnerable group. It was done, shielding was done even in UK. But that does not mean that they cannot actually provide them support. Or now we actually have WhatsApp, video calls, those kinds of support can still be provided to them. And they should be actually be clear that there should be a clear kind of, rota for everyone. Is said this day is this person, this day this person. They can still remain at home and still be available. So that should be very clear to them. So other institutes are doing really, really well. I mean, they are actually all consultant-led, and juniors get all the support. So I think it's unfortunate we do not actually have NHS kind of healthcare system in India.
Dominic, any comments, any questions?
Well, I suppose my overall, I mean, it's a very good presentation because I thought it followed on very nicely from my sort of wider context to actually the detail of actually working within the unit, which complemented that. So that was so well done for that. But what I would say is this: is that it's an obligation on all of us. I mean, my personal belief is that health and care is a universal obligation and right for every single person on this planet. It should not be driven by any other factor, not finance, not politics, any other factor. If you cannot look after the health and welfare of our population, what can we do? It's the minimum requirement, but there's an obligation on us all as a right. And that obligation is to actually provide the support that's required. So while I fully understand people are making decisions about their personal circumstance and their personal level of exposure, particularly, as we said, we've lost clinicians in the UK, and some of that was due to some of our retiring clinicians coming back who were in vulnerable groups, being exposed. There's lessons to be learned right across the board with this pandemic. But one of the things I would say is that we have to create those routes. We have to create those support routes. We talked about leadership, about support and trust. So even if you don't want to be in the room, there has to be a way to put your hand up. There has to be a way to get an answer, even if it's not immediate. You have to do that. And in fact, if you can create that can sometimes have a much bigger effect by just creating that process and that route. You can get many people supported. We found quite a few years ago in the UK, there was an effort to try to get clinical advice out to the islands and the Outer Hebrides, and they set this video link up with Inverness Hospital, and after a while it wasn't being used, and people started questioning it and saying, well, why wasn't it being used? And the answer was because the information had been transferred. people had got the answers, and they started to then transfer the information amongst themselves. So they needed to pick up the phone or the video link less and less. And it was really just about creating those really simple ways of getting an expert in the room. And that's the way I just do it. How do you get an expert in the room? If I'm in a junior now in an ITU unit and I'm struggling, where do I get that expert advice from? And, listening to your presentation, it was very clear that sometimes you just need that clinical hierarchy, that supervision, just to say, yeah, actually what you're doing is right, and what you're doing is wrong. Have the strength to put your hand up and have the strength to take the answer. But as senior clinicians, we have to provide that. We have to provide that support and trust. That's what leadership is really about.
It's unfortunate that there's hierarchy within the Indian system. It's inbuilt there. That is one thing, and so it has got its positives, but in this situation, it becomes a negative here. And because of the hierarchy, the junior is unable to question the senior. He cannot. He feels.
What I would say is that is no different than the UK. Okay, although those boundaries might be less, that we have a very hierarchical system. If you look at even our country as a whole as a monarchy, we have a hierarchical system, and it does not lend itself to immediate transfer of information and knowledge. But in a crisis, we do not have that luxury. We just do not have that luxury. We saw that in Fukushima, waiting to be told what to do when you know what to do, waiting to get the authority. It was too late. It was too late. We have to act now. We have to put those things in place. So we all have to be honest and recognize that hierarchical systems are part of our problem. So we have to find a way around that if we're going to deal with this crisis.
You have to, yeah. I think that the other problem, which I think Dheeraj already told you about, is in India, is that the violence and aggression, which actually happens at times when things go wrong. And this is just not a single person. So here it's not actually having conversation or shouting at each other. It's actually a mob. The whole family actually comes on to the doctor. And there is actually no way to protect them. So I think the hospital should be providing that protection to the doctor, but it doesn't actually happen at times. So that's another problem, which whatever we talk about leadership and protocols and things, those kinds of things don't work in there. We can't do anything.
That is very true, and I take that point on. Having seen that not just in the Asian subcontinent, but seen that in Africa in responses that we've done, and it's very difficult to control a mob. Surprisingly, one of the things we teach in disaster response that actually a piece of string, a line, has the ability to be able to control a mob. Because when people see a barrier, they have to make a question: do I cross that? It's a decision. Do I cross that barrier or don't I? And if you can set it up, so we would literally watch people try to manage disaster in chaos as an exercise, and then we would just point out some really simple things to them. Why don't you set up that line and show people which is the route in and which is the route out? And then you'll be surprised how people start. We're very good at queuing, in India and in the UK. We love a queue. We'll join a queue just for the sake of it sometimes. So, if you can set it up correctly, you can put those barriers in place. And it is requirement on hospitals. Managers in hospitals cannot, shake this responsibility. There is a requirement to protect our clinical staff. They're in a very difficult situation. As we said before, they're having to make some very, very tough decisions. And what we said in the UK and advised the UK government was that you should set up these clinical decision-making groups, these clinical support, to make sure that people are being supported and recognise that actually they're having difficulty making their decisions. But what goes alongside that is actually the practical support about making sure your staff are protected. There is no excuse in a hospital not to protect your staff. If we lose our staff, then we've lost our ability to be able to respond.
Very true, very true. I think, like I said, it is about the team. So I think the concept of circle is exactly circle-based about, come on, let's gather up and support each other. So that's what we were talking about. So that should be the concept. And there, everybody, see, other thing which I actually didn't discuss in that part was that you can also delegate. So it doesn't mean that just because you're a doctor, you have to be the leader there. You can each day decide, you say, okay, you can lead this briefing, debriefing, and micro checks. So anybody can actually do that. You can actually then empower the other members of the team as well. So it doesn't have to be a single person. So delegating is also another part of leadership.
I would say it's absolutely fundamental in crisis response. Empowerment is fundamental because no one person or even one team or even one country is going to solve this issue. We have to empower everyone to be able to act within reason, within, be able to justify their actions, within guidance, within criteria, within protection. But we have to empower people. And it is the clinical wealth of our clinicians around the world that's going to save us in this pandemic. We have to all recognize it's the clinical wealth that's going to do this.
Absolutely. Absolutely.
All right, Shiv, I can see the clock behind you, and it's 2 o'clock now in the UK.
It is.
It's probably coming to very, very close to our sort of bedtime. So, Teju, I think I'll let you finish this off with any of your thoughts.
So I think I liked all the talks. Only thing that I would like to emphasize is the thing that helped us the most, that made us feel empowered when we were going through the COVID outbreak. That was in the beginning phase, was one of the most senior clinicians taking up the role of counseling.
Yeah.
So she took up the role of being a counselor. She was very empathetic. She came to me. I was just recovering from my surgery. So she was like, "Are you sure you want to work in the COVID ward?" So at that time, I just felt like I'm trained for this. So I would want to do it. So it was more like I felt empowered because she asked me that. Just one simple thing. I know you've been through a lot. Do you really want to do this? And that kind of liberty is what I felt was most empowering, and it was most encouraging as well. So it was like they would do debriefs every week, saying that, look, we are all senior guys. And then if there is my consultant who's standing next to me, I know he is over 60, he is at higher risk of catching this infection than me. So I felt like, that's fine, I'm going to do this. Just teach me, just ensure that I'm wearing my PPE properly, I'm donning and doffing it off properly. So he stood there by me, just supporting me. He didn't enter the COVID isolation room, but then he was there. Just the presence made that sort of comfort and confidence that everything's going to be okay. So even if somebody is not able to do whatever we are expected, I mean, like if seniors are not able to enter the rooms, that's fine. If they can just ensure that they have an overall view of everything, and then just to say to the juniors that it's going to be fine, you will be all right, just do this properly. So that is one thing which really helped us. And second thing which I wanted to highlight is that even though there is that divide of hierarchical system wherein you don't feel comfortable approaching your seniors, but then there would be one person in the department with whom you really gel well. So that confidentiality and trust, and ensuring that whatever remains between the student and the bosses, candidate, trainees and the bosses, that confidentiality is something that really helps people get over this. And one more point about the mob thing. It's usually the person who has never spoken to the doctor who comes with the mob to assault. So like Dr. Dominic was mentioning, the wall that you can create between this mob and yourself is actually having confidence of one of the relatives. So whenever I'm doing counseling for any patient in ICU, I ensure that I speak to the same person every day. And if that person is not there, I was like, oh, I spoke to him yesterday. Can you call him as well? So even if he is on the phone, it really, he would be that wall. He would say, this doctor is nice. He is helping us out. So let's not do this. So he would form that barrier. So I think that kind of relationship usually helps in protecting ourselves from the mob, I felt.
That's a very good answer, Tej.
Yeah, I think that's excellent. And I think, a lot of departments went and had what is called as a well-being lead. I mean, what I found very useful, I mean, towards the first wave, I worked a lot. Towards the second wave, because of my health, they made me do a lot of anesthetics rather than ITU. And it was very supportive, the department. And we had something called as well-being leads. But what I found worked for me was to find a well-being buddy. Okay, yeah. My buddy whom I talk, and what people don't realize is that it's not just with junior doctors, it's the consultant. Every one of us went through the same pressure. Everyone had the same problem. And I had a couple of well-being buddies whom at the end of the shift, I used to call and I say, listen, this is what happened. What do you think? What did I do? What should I do? And the same thing used to come back. And we had a lot of, so I think we had a lot of, we had a group, like we circled up literally every day in the morning during our handovers, in the evening in the handovers, we used to circle up, we used to talk, and we had reassurances from the people around us, and we had people asking us. And there were small things like the trust were doing, distributing a fruit or a chocolate or a bag. So many people around the region in the NHS where we worked were so kind. We were having goodies and food come on a daily basis. The community really, really pulled up, and they played such a vital role in actually helping us tide this crisis. Whether it was clapping for the heroes on a Thursday evening, to we had a gurudwara nearby who used to deliver excellent curries. It was fantastic. So I don't think so without this kind of support, without having support from the community, patients coming back telling thank you, going on the news with that, saying that this hospital helped me recover. We used to have this clapathons for every patient who was leaving the ITUs in the beginning. All that was so important just to keep your morale up, because I think that is the main thing which we require, because whatever everyone is doing is making a difference. Just keep it up. I don't think so, that there's anything more we can do. All right. So I think it's time to end this, Shiv.
Yeah, I think so. Yeah.
I'd like to thank Dominic especially because, I think we speak a lot on the forum, but taking his time, spending the last 3 hours with us, thank you very much. I think your talk was excellent. I have learned a lot from it, and I think all the other people who are watching this would have learned a lot. Thank you very much.
Can I just say that that offer exists? If there's anyone else you want me to talk to, we're all in this together. All in this together.
Oh, that's very kind of you, Dominic, and thank you so much. Thank you, Dheeraj and Teju, and goodbye.
Yeah, Shiv. Thanks to you.
Bye.